welcome to Lion 2021. We sat here just a year ago at the beginning of COVID, trying to bring doctors, patients, and colleagues together around the world. And many of us thought we wouldn't be doing this again, but we're still stuck with this plague. Before we start, I think we should think about our colleagues that haven't been able to connect. We have Mohan Kameshwaran in Chennai in India, and unfortunately we had a message 2 days ago to say his hospital was literally in meltdown because of the crisis. So Mohan's fine, but our thoughts go to them, and to Oswaldo Cruz in Brazil. Last year we managed to bring 93 countries together. We hope we'll be able to do that again. We've got some very experienced surgeons that you're going to see today. All levels of, from trainee to consultant, will be watching, and we would really like you to use the media feeds so that we can try and answer as many questions as possible and keep everything interactive, as Wilco was saying. I think it would be a good idea to get our colleagues to introduce themselves. I'm at the end of my career retiring from otology, and because of that, we wanted to involve some new blood. So we've brought in Nina Mistry, who's a specialist just starting, but with a good scientific background, thesis, etc. And she's starting in Worcester in the UK. And tomorrow we'll have Emma Stapleton, who's a specialist who's 3 years in with experience in skull base and implantation. And of course, we've got Wilco, who will explain himself in a minute. So over to Nina.
Hello, good morning, everybody. Firstly, I'd like to thank the Lion Organising Committee for inviting me here today. It's a real honour to be able to moderate with John Oates today and with Professor Wilco Groman. So thank you very much for having me. As John was saying, I'm starting out as a consultant, so I've been appointed as a consultant otologist and general ENT surgeon at Worcester Royal Hospital, which is again in the West Midlands. I've just actually completed a fellowship which was in complex middle ear surgery, cholesteatoma surgery using the laser and endoscopic ear surgery, and that was with Mr. John Hamilton and Mr. Matt Clark in Gloucester Royal Hospital. I do have some research background as well. I did an MD at the UCL Ear Institute with Professor Shaq Saeed, and that was looking at cochlear implantation. I'm really excited to be here today. I think there's some really excellent surgeries lined up, and I look forward to speaking to the surgeons in their respective operating rooms and forwarding on your questions and queries that you may have. So as John said, please do interact with us on the social media platforms, on Zoom and on YouTube, and we will of course pass on those questions to the experts so we can get the answers to you. Thank you.
Thank you very much. Thank you. We're very honored that you're with us. I just want to demonstrate now, if you see, these are the surgeons that are being prepped. I see that Dr. Vincent is quite far in his preparation. So I would suggest, John, and if Nina, if you agree, that we move to Robert Vincent in the Béziers Coast Ear Clinic, because I think he's ready, and we'll have to see if it all works well. Okay. Hello, Robert.
Hello. How are you?
Well, we are fine.
I can see you. I can see you on the right side. I can see the camera, so it's fine. I'm fine. And you? Everything's fine?
Here is everything fine, and I think in England as well, of course. We truly have to express our gratitude to you, but also especially to the patients and Celine, of course, who's there with you. That we're all working on this. I think it's fantastic. So, Robert,
well, it's your home here, Wilco, now, because you're a member of the otology group, huh? So it's fine. You know everybody yes. here, and they're waiting for you again.
Yeah, we just said. Very good, Robert. Can you please explain what you're going to do? I did not show. If you like, I can show the case presentation. Then I will mute you for a moment. And
yeah,
John,
okay, let's do that.
Okay.
And
John,
just before that, I just must say something that. All the job you made, specifically you, Wilco, but also John, you made a wonderful job this year to make it possible. So I just want to thank you very much for all the effort you put in this.
It's my pleasure. It's all about education and friendship, of course.
Yeah. Sure.
So, John, this is the case presentation, or maybe Robert can do it himself. I need to make sure that I didn't mute him while we were doing this. Hold on, Robert. Yes, I muted you by accident. Sorry about that, Robert. So, can you explain the case yourself? I'll advance the slides.
Okay.
So,
Well,
of course,
just,
these are the sponsors, and this is the case.
Yeah. So that's the for the first case, it's going to be a primary surgery, which is supposed to be a stapy surgery. So you can see I'm going to do a right side stapedotomy with vein graft deposition, which is supposed to be the technique. And I'm supposed to use also a 0.4 millimeter diameter Teflon piston. So you can see the history of this progressive left bilateral hearing loss with the left stapedotomy, which I did in 2002 with quite a good result and stable in time. And now we have to perform the opposite ear because the patient is complaining for a right progressive hearing loss since few years. You can see the audiometric test with a clear right side airborne gap. All right, so you know in this technique I'm performing this COS technique, and I've already made the incision on the dorsal face of the hand to catch up some vein graft, which I found already, and which I'm going to take. So the vein is used to seal the labyrinth. That's the point of this technique. So we use a very small incision. I hope you can see the vein here. Michel, tu peux faire un zoom peut-être? Okay. All right. Peut-être la lumière, on enlève là. Il y a trop de lumière. There's too much light. We're going to decrease that. Don't worry.
So, Robert, while you're doing that was an interesting audiogram. The patient appeared to me to have about a 25 dB conductive loss. Do you have a level that you like to see before you'll operate? 20 dB, 30 dB?
No,
less than that?
Usually I prefer to wait for something like 30 dB, but 25, 30 dB is the minimum airborne gap I like to have before performing surgery. But you know, John, it's always depending on case by case. It's a case by case discussion because you have some patient where sometimes you have to wait and you don't see a clear 25 dB airborne gap, and the patient still complains. And then at one time you have to make a decision. But to the young surgeon, I would say it's better to wait for having at least 25, 30 dB airborne gap before performing stapedotomy.
I think what our young colleagues have to understand is there's a cost risk lifetime benefit equation, isn't there? And yes. I think 30 dB is probably the level relatively beginner surgeons should be thinking of. I don't know about you, Nina. Do you have any views on that?
No, I think I would agree. I think I was going to ask Dr. Vonson, actually, apart from the audiogram, do you do any other testing preoperatively?
Well, we now we need to perform a CT scan. This is mandatory in France now, which I don't believe it's very interesting because in the vast majority of cases it doesn't show anything. And the main aim of that is to rule out any dehiscence of the superior semicircular canal, which is very rare. And there are many cases where even a good CT scan doesn't show anything in the middle ear in terms of otosclerotic focus. So my personal view is that I consider that the CT scan, the pre-op CT scan, is just not really interesting. And I think it's quite a bit stupid decision, but this has been done and now we have to do it. I would consider that more important for revision, but that's what we have to do. I also do the turning fork, which is the clinical, test. And that's all I asked for. And I'm happy you be there. It's nice to see you again.
Oh, it's very nice to be here. I feel very honoured to be here and to be joining you today.
Good.
I'd second that, Robert. I think the tuning fork was a very important comment there. When it comes to believing the audiogram or the tuning fork, my advice would be always favour the tuning fork. If the tuning fork doesn't fit, get the audiogram repeated.
Yeah, that's right. It's a very important test, to be sure. Yeah. Okay,
perhaps
so I'm
perhaps you could comment on the position, Robert.
Yeah, I can show you this. Maybe you can see. Attends, reste encore sur le champ, hein, Michel. So this is the position of the patient, which is lying down like this. I'm on his right side because this is going to be a right stapedotomy. You can see we have this speculum holder. there is a plate which is positioned underneath the head of a patient, and this is going into the plate. So this allows me to have a very stable position, and this will fix the speculum. And this is going to be, of course, a transcanal approach. So, of course, I like to have both hands free. Definitely, this is a minimally invasive surgery, just like the same approach for endoscopy. So I just do a posterior incision, elevating the flap, and having the same approach. And then performing everything via transcanal. Table en avant encore, s'il vous plaît.
Well, you've opened a can of worms there, Robert, by mentioning endoscopy. Do you personally see a role for the endoscope in performing stapes surgery?
Hold on, one second. Je crois que je suis pas bien à l'aise là sur ma vue, Céline. Au niveau
It's a good question, John.
C'est pas sorti.
To get him
I'm
fired up during the surgery. Very good. No respect for the surgeon at all.
No, what I'm thinking, let me tell you something. I'm not absolutely against endoscopy. I think it's a very nice tool, and some surgeons are really very impressive with that. But if you look about what they think, why it is important to have endoscopy, what they say is that we've had the minimally invasive procedure in terms of approach, but that's the same as the one I'm doing. There's no difference. And the second thing is that they also say we have really nice picture, but I think we need to remember that we do surgery not for the picture, but for the patient. But anyway, I like to have good picture too. And if you look what we have now, if we look to my YouTube channel and the result that I have with the 4K system, I think the quality is exactly the same. So I don't see any difference in those two types of techniques. And on the other side, I'm losing one hand if I'm doing endoscopy. So I prefer to have both hands free. This is my position, but I'm just saying I don't have experience in that. So I cannot comment too much, but this is exactly what I think. Okay. All right.
Well, I would agree entirely with you, but there are people who will call us dinosaurs. But we'll see what Nina says.
We are dinosaurs. We are dinosaurs. Okay, anyway, okay. So now this is the preparation of the vein. So I took the vein from the dorsal face of the hand, and now what I'm going to do is to remove the perivenous connective tissue. I can increase the light. I think it would be better for you. All right. So you can see that the nurse is holding the vein, and I'm going now to grab the perivenous connective tissue from the lateral side of the vein and try to dissect this vein graft to remove the connective tissue from this side, because I like to have a thin vein. And now I'm going to open the vein, and in order to have access to the intima of the vein. So I'm going to open it like this. And I'm going to
Dr. Vincent, do you...
Yeah.
I was just going to say, you mentioned about having the intimal side exposed. Do you have a preference as to which way you put the vein graft in, which side down?
So now we are facing now the intima of the vein. The sticky side is the adventitial side, which is that one. So this one, the sticky side, the lateral side should go to the foot plate, whereas the intima should face the surgeon. Okay?
Okay.
And I'm going to just to pre-shape the vein. So I'm going to cut the vein and just keep only a small part of the vein and push it into the glass, into the glass hole that we have. You can see the hole in the middle of the glass. This is a nice way to pre-shape the vein. This helps me to prepare the vein. I will push the vein down into the hole and leave it like this until the end of the procedure. So the part around will stay wet while the external part will dry. So I'm going to push it like this.
Robert.
So this is kind of a shape we have. Yes.
Can you please explain what you did? Because you pushed the knife through the vein graft and you didn't cut it. Can you explain
Sorry,
why.
say it again.
Well, when doing this technique, I've noticed that it's quite difficult to cut the vein graft at the exact right size.
I understand what you mean.
And what you taught me, I must admit, is that you shouldn't cut it, but you should push it through the vein. Can you explain how you do it? Can you show that again, maybe?
I show it again if you want. Vous avez le reste de veine, s'il vous plaît? Let me show you this trick. It's a good point. It's a good point. Show. Je vais prendre le petit morceau. On me le met dessus, juste pour leur montrer comment. So I'm going to show you with the residual part of the vein, which I sometimes use if I have a tear of the skin or something like that. So if you want to cut the vein like this, so let's put it on the right position. You're now facing the intima. I want to cut it here, for example. If you cut it like this, it's going to be difficult. So what I do, I just put the knife over the vein and do small movement like this in 2-3 times, like this, and then like this. Because if you cut it like this, it's not easy. And now you have the right size. Okay?
I just add here as a tip for younger specialists, using a glass block like Robert is using is much better than using a metal block. If you use a metal block, however careful you are, it will have scratches on it and the vein adheres to it. Whereas the glass block, when it comes to use it, you can just peel it off.
Yeah, good point. Did you try to use a metallic
yeah,
plate,
well, I've
John?
never managed to get. Yes, I have a metal block. I have a Moretz block.
Okay,
we mustn't upset Bill because he might be listening.
You are definitely a dinosaur, right, John? I know that.
I am. Yeah. But this is a unique moment in line transmissions. We're 16 years in, and it's the first time that you've pronounced tear correctly. You always say tear.
No,
so
it's
obviously
not true.
your English is now better than mine.
Your last remark is correct, John.
Yeah. So what have you put down the ear canal? What is this? Is this povidone iodine or betadine?
Yeah, it's a mixture of betadine. Yeah, that's it. And I'm trying to find the right size of speculum and the right position of the head of a patient. I must say this patient is having a very short neck, and it's not sometimes easy to have a clear exposure in this case. So let me show you the infiltration now. This is 12 o'clock. So I will infiltrate usually with a mixture of Xyloca and adrenaline at 12 o'clock here, and also at 6 o'clock right here. So only 2 spots.
So by 12 o'clock, you mean the vertex, the top of the head? Yeah.
Yes. Yeah. There we go.
Robert,
Dr. Foxon, can I? Oh,
go ahead,
yeah.
Nina.
Sorry, John. So I was just going to ask you mentioned about obviously we're doing it a transcanal approach and permeately. Do you have a minimum size speculum that you know you're going to be able to do it via that technique? Do you ever have to perform an endural, perhaps in some patients with very narrow canals? And do you have a cutoff in terms of the size of the speculum when you know you're going to have to do that?
That's a good question. I never had to move to endural, even for congenital malformation. Usually for the primary otosclerosis or revision, but I mean otosclerosis surgery, usually even when you have a very narrow canal, it's not less than, I would say minimum would be 5.5 millimeter diameter.
Okay.
But in congenital malformation, I had cases where I had to use a 4.5 millimeter, 4.5 millimeter diameter speculums. And then in that case, I could do it. You just have to do a bony rim resection, which is going to be a little bit larger than usual. But usually with patient, you can do it. If it's
the speculum, the speculum holder makes a big difference, doesn't it? I think.
Oh yeah, exactly. Yeah. But if it's really small, if you cannot use a speculum, then we do that in 2 stages. We do a canalplasty first, and then do the stapy surgery later.
Okay.
Well, it's interesting, Robert, because Chris Holden and I were discussing this last year when you did your transmission, and we used exactly the same technique as you. I have had to use an endural or a canaloplasty once in just under 1,400 cases, and Chris hasn't had to do one at all. And he said he's operated down to 3.5 millimeters. So I don't really believe personally that an end oral slit makes a difference. But we're going to see at least 2 or 3 other surgeons today, 1 or 2 of whom may use an end oral slit. So it'll be interesting to ask them what they see as the advantage.
Well, John, that's an interesting discussion. Robert, I think we should at least communicate with Munich at this point for a moment to see, because officially they start at the same time.
Yeah, please do it.
And as soon as we can at least check what the status is with Hanover.
Yeah.
I mean Hanover, not Munich. Hello, Thomas. Can you hear us? Yes. Hello. Sorry, it's my fault. Thomas, can you hear us? Hello, Thomas. Hanover. John, can you talk to Hanover, or Nina, your audio?
Thomas, can you hear me? In Hanover? Thomas, can you hear me?
Hello.
We don't get, I think the sound is
No,
off.
he can't hear
Hanover.
us. But we can see this is his case here, which
yes,
appears to be a right-sided conductive hearing loss with about a 25 to 30 dB air-bone gap and perhaps some cochlear loss in the lower frequencies.
Okay.
I can hear sound coming back from his theatre.
Where?
Thomas, can you hear us in Hanover?
John, maybe you can come back to me and then just explain the beginning of my procedure.
Yeah.
Okay.
Let's go back to Robert. We'll go. Okay,
so
Robert.
Dr. Vonson.
Nice view.
Okay, we are.
Oh, sorry, John. I've just had a question through on the Zoom, actually, for Dr. Vonson. Somebody's asking whether a vein graft is always necessary in all cases of staphydotomy.
Well, the question is, why do I use it? I believe the vein graft will seal perfectly the labyrinth. That's the main point. It doesn't make any difference, I think, in terms of hearing outcomes, in terms of functional results. But I think it helps to seal the labyrinth and to decrease the risk of postoperative vertigo. And to be honest, all my patients are staying 1 week here in the clinic. That's my protocol, and they accept to do that. And I can follow them over the week. And it's extremely rare that a patient complains for any type of dizziness postoperatively, even small one. In the vast majority of cases, you don't have anything. And I think that's related to the vein graft. But it's not mandatory, but I do it for all cases. Yeah.
Thank you.
I mean, I'd second that, Robert. We can't prove that a vein graft is beneficial at any of us, but I certainly have patients who are told not to lift or take vigorous exercise for 3 or 4 weeks after surgery, but they immediately go out jogging or to the gym. And as of now, I've not had a problem. And I honestly believe that the vein does give you some protection. The problem is here, you have to do so many thousand cases to prove it, because a fistula is so rare, perilymph fistula, that I don't suppose we'll ever know.
Yeah. So just to explain the beginning, I'm going to make a skin incision running from 6 o'clock here to 12 o'clock. I remind you that's a right ear. So this is exactly the position I like to have, the exposure I like to have. I use this round knife, and I put it at the distal tip of the speculum and make a circular incision here all around from 6 to 12. And I need to force a little bit, to push a little bit the knife to be sure that I have a good contact with the bone. And now I'm going to elevate the flap. And for doing this, I use a kind of a smooth elevator like this. And I'm trying to follow a kind of horizontal line.
Kann ich mal abnehmen, bitte?
Okay, we're getting some cross-talk from Hanover. Can you mute them, please?
No problem.
It's all right, Robert. We're still with you. We'll go to Hanover in a minute.
Test, Wilco.
Okay. All right.
Robert, hold on 1 second. I want to
Yeah.
see if we can move to Hanover for a moment. Hello, Hanover.
Hello, Wilco, can you hear me?
Yeah.
Can you hear me?
Yes, I can hear you, Thomas, quite clearly,
Okay.
and we can see the picture
Okay.
of your case.
Okay. To the technician who's in Hanover, you're sitting in Hanover. You're sitting in one stream. That's why I can hear you. Okay. Continue. Thomas, can you please explain your case?
Okay, can you hear me?
Yes.
Yes.
Can you hear me?
Yes.
Can you hear me? Okay, great. So it's a young lady, Tim, wenn Sie es kurz zeigen, bitte, with a conductive hearing loss on the right ear. So, also, mit dem Finger draufgehen einfach, ne, danke. And she has progressive hearing loss. You see in the audiogram. So the Weber goes to right, and the Rinne is negative on the right ear. Looking on the CT scan, we basically can see there is a regular anatomy. Bisschen größer machen. You see here, we see the oval niche ein bisschen schärfer machen, bitte. Wenn Sie es machen können, Tim. The oval niche and also regular cochlear anatomy. So now we have already started here with transmeatal approach. Können wir auf das Mikroskopbild gehen, bitte? Kann man das ein bisschen rüberfahren, dann kriege ich ein steifes Knick. So. Können wir das Mikroskopbild bitte schalten? Danke, yeah, now, okay, you see, now the transmeatal approach. We have, I think, here number 7 as a speculum. And so I just started to open here the middle ear. You see here, that is the bone, posterior, superior. And now I just started to elevate the tympanomeatal flap, staying very close here to the bone so that we don't injure the skin nor the, bitte mal den Sauger eins kleiner. And we needed das Messer bitte, das Pflastermesser. Nicht, Entschuldigung, nur das Sichelmesser bitte. And you see here now that is the basically the annulus, so we can now go into the middle ear. The surgery is done under general anesthesia. Sometimes we also do it under local. We see already here the chain, and now we can here look for the chorda, no? The chorda tympani, which basically crosses here over the incus. You see here we can elevate it now and dissect it off, because the chorda is something we should preserve. Not possible in all cases, but most cases it is. So you see here we get quite good free room, and next step is then that I go for the dissection here, remove some bone using a drill, so that we have more exposure on the stapes tendon is down here. And so I hope the picture is okay.
Yeah, it's good, Thomas. I would say this is the luck of the Germans. This is actually a very good view already. You won't have to do very much.
Use the osteostructural, which is BNR osteostap, yeah, which I think is quite nicely done. You also can use a house curette for removing the bone, whatever you prefer. I think there is no clear advantage or disadvantage from one or the other, depending on what you are used to. So here you see the drill, and I have to switch it on. So okay, so we need a bit of irrigation in order to prevent overheating. As I said, it's already well exposed. So now we can basically just do some work here. Perhaps not so exciting, but
What I can see,
sorry for intervening. Robert does exactly the same thing,
but in a different way.
So I switch to Robert for one.
So Robert, we could see
Okay, back with me. What I'm
Yes,
doing here is
yeah.
a bony rim resection.
Yeah,
I'm just waiting for you a little bit, and then you see I'm using the curette to do that. I don't really like to do a burr like Thomas does, which is really nice, but I don't like it myself because I can see that it creates some bone dust into the middle ear, and I prefer to use the curette. So, but that's the
Perhaps
same
you could
point.
comment,
I mean,
Robert, exactly. Perhaps you could comment exactly on the curette movements, because that's something that a lot of trainees have problems with.
yeah. Well, for the right ear, you have to start from here, okay, over the incus. What we want to do is to expose the facial nerve, but not overexpose the incus. So I'm always starting like this, with the rotating movement like this, and never on the other side, because the risk if you start from here is to dislocate the incus. So it's important to do it step by step, and try to at the end have a clear exposure of that. What I want to have is having a exposure of the facial nerve here on the left, but also the pyramidal process here on the right. And you see there is some residual bone here. So I'm going to remove this bone to have even a better exposure of the upper window. So let me curette encore.
so,
All right. So
it's
in
interesting
that
what you
case, I
say
use
there. I mean,
the
one
other
of the
side,
things is you have to be very careful with the curette that if you go
yes,
in a superior direction, that you don't take a big flake of bone off, because the drum
yeah,
will then
exactly.
drape post-operatively. And these are French curettes. They're bang up to date. The British curettes were fashioned in the Iron Age and the Stone Age, but this is a really good curette, and probably the most important tool, or one of the most important tools in this operation.
John, stop bashing the
Well, but-
British system.
Yeah,
John,
You know
John,
that
can you
everything's
make the
we've
comparison?
got their
Now,
fish, right?
You know that.
Yeah,
Can
yeah,
we?
but
All right.
uh,
So
hold
let me
on,
show
hold on,
the-
hold on, Robert. John, can you make the comparison? Because I think it's a very nice comparison. What you see now, we see Hanover on the right side, and we see Béziers on the left side.
Yes.
Same approach.
Same approach.
Different.
Different.
Can you say something about this?
Can you say
Yeah, well, I think
Nina, maybe?
getting a lot of feedback from Hanover. I think these are both excellent techniques. Personally, when I use a drill, I'm concerned that the corda will end up wrapped around it. But Thomas spends his whole time with a micro drill, so he's obviously very experienced.
No,
It's not
don't
having a
worry.
problem.
Please don't say it, John. Don't
I,
make me nervous. You see,
I think
it's kind of.
I think you've both got when you both opened the middle ear, you've both had a reasonable view of the incus medial joint. You can't pick patients like that in advance, but these are good patients.
Okay. Yep. Yeah, so I just have to remove a bit of bone. You are right, John. So I have to be very careful with the drill. Sometimes it's jumping, no? You also have to be careful that the drill does not basically move in the corda into the area. And here now, I think we have a good exposure still to go a bit further down with a mild Sichermesser. And I try to, we see the facial nerve very well. It's no problem. So here you see a bit of bone left. You can move out the corda of the space here. And you also can use a combination of both techniques, the curette and so I think I have to remove a bit more bone here. What I will do now. Yes, of course, to the master.
Okay, Robert, we're back with you, and that's a really nice view showing all the important features.
Yeah.
Perhaps you'd like to point them out for the audience.
Yeah, sure. Oh, so we have now the incus, and we have the stapes here, a pretty narrow gap here between the superstructure and the facial nerve. And what I'm going to do now is to separate the incus from the stapes, opening the incudiostapetal joint. So I'm I got this idea from you, John, elevating a little bit the incus to find the joint, so you can see the joint moving here. And then I'm using the joint knife to to go into the joint, and I like to use the sucker to stabilize the incus when I'm doing this. I mean, this is the reason why I like to have both hands free. All these small details, it's important. So like this, and now I can check the ossicular chain mobility. First of all, malleus, incus, and then stapes. So I'm moving the malleus, and you see that malleus, incus are mobile. And I'm going to move the stapes from the top of the head, and you can see it's completely fixed. So next step will be to use the laser, which is going to be the luminase system with the autolase. But first, I need to cut the tendon. You can use the laser, of course, to cut the tendon, but I just cut it while we're preparing the laser. And now I'm going to vaporize the posterior crus. The point now will be to remove the superstructure. So I'm going to use a combination of laser and micro drill. 3 watts, s'il vous plaît. 4 watts, pardon.
Can I just make an important point there, Robert? You know, you and I and Wilco get revisions from other surgeons, quite often done by senior trainees or senior residents, where they say, I couldn't persuade myself that the stapes was fixed. And when you look at the operation note, they haven't separated the incostapedial joint. For the audience, it's probably the most important part of the procedure is to separate the joint so you can palpate the stapes out of continuity, and then you can make a judgment as to whether it's fixed or not.
Okay, that's right. Good point. So I'm going to use the laser away, a little bit away from the posterior crus. Okay. So it's a beautiful system. This is a CO2 laser, which is very safe. We all know that is the safest one compared to the other one, KTP or argon and everything. And even diode laser is not that safe. Because you know, a CO2 is completely absorbed by the perineum. Now I can have a nice view of the anterior crus, which is not always the same, right? So what you can see, I'm not using only the laser. The laser helps me to prepare the drilling out procedure, and I'm going to use now the Skeeter, which is not a Skeeter, by the way. It's a BNR system, and with a 0.7 millimeter burr. And you know, it's pretty narrow because I can have access now only because I'm trying to enter this gap. And now just leaving the burr doing the job by itself. No pressure, just, and the laser helps. And it's a low speed drill. So you can see also the position of the sucker. You can use it to stabilize the superstructure. What I have now is a very thick posterior crus, in fact.
So Dr. Vonson, are you, sorry,
yes.
you mentioned about the anterior crus and not always being able to visualize it so clearly.
Yeah.
Do you have any tips for surgeons if that's the case? Is there anything that you can do to improve it, or, you know, any sort of, you know, ways in which you can ensure that you are on the anterior crus when you're lasering it? Just any tips that you might have.
Well, not really. You just have to place your burr between the facial nerve and the superstructure like this, and try to reach the anterior crus by palpating it. But that's the only trick that I have. There's no other way.
I mean, the other thing I would say is if it proves impossible to see and you can't get at it, very occasionally you end up having to down fracture it. And remember, the anterior crus is much more vestigial than the posterior crus. So it's unlikely that you're going to start a floating foot plate.
But it's not always. Sometimes you have a thick anterior crus, so it's always better not to try to fracture it. But it's true, John, and sometimes you must do it. C'est bouché. Okay, I remove the superstructure. We'll still have a narrow oval window, so I may have to drill out a little bit of promontory to have a better access to the foot plate. We'll see. Yes, I have to do it a little bit.
John, can you read the messages to the surgeon, because they can?
Yeah, we had one question a few minutes ago, which again was asking why you use a vein graft. I think we've covered that, you know, because we believe it caused a seal. He was just pointing out that most surgeons don't use a seal. I think I would argue with that is most surgeons don't use a vein graft, but they do put quite often some kind of material, fat or blood clot or something around the piston. So obviously they believe that you can get a leak. And then the second one was a thank you from one of your visiting fellows from abroad who enjoyed working with you. That's Basim Daja.
Mark Basim, yes, I remember her.
No, not Mark.
No, it's not Mark.
Oh,
No, it's not Mark.
yeah, I remember. So I'm measuring now the distance from the incus to the footplate, which is, the second hook is in front of the incus, which means 4 millimeter. I'm using the mid surface.
Do you mean the
incus.
midpoint of the midpoint of the incus, or do you mean underneath the incus?
No,
The
the
midpoint. Okay.
Okay.
Robert, do you mind if we have a look at Hanover for a moment? Because both procedures move on swiftly on both sides.
I'll be waiting for you for the stapedotomy procedure.
Okay, thanks.
No problem.
Okay, Hanover, we're back with you.
Hello. So
yes,
now
hello.
We have done some work. My Blästermesser, bitte.
Your audio can be a little bit louder, please. A little bit, just a little bit.
Yeah, okay. Good. Can you hear me now?
Yes.
Can you hear me?
Yes, we can hear you.
We can hear you.
Okay, great. So Hex 0,6 bitte. Okay, now we see we have done this exposure. We removed a lot of bone, which probably is a bit too much, but it's never too much, so to say. And you see here now we have elevated also the drum. So now we can go for checking the mobility. Nochmal die Nadel bitte. We have a nice view down to the footplate, and it's a 0.7. You see here just the mobility of the incus is there, and when we go for the stapes is, so to say, fixed. I can't move it. It's very much fixed. So the posterior cruise is red. I hope that we can show that too. So now we have to measure the distance from the footplate to the incus. Nochmal das Messtool. And show you. Here you see the. So now we go with this the kind of fish tool. We just measure from the footplate here to the incus, and it's the 5 millimeter hook is over the incus. The 4.5 is just there. So we will cut the prosthesis to 5 millimeters. And before we do that, bitte mal das Scherchen, Bellucci Klein. We'll cut the stapes tendon. So, and then we use the Kleines Bellucci.
I'm just going to talk over you for a minute, Thomas, because there's some questions coming in. There was a question there. Do you do a CT scan for every case of otosclerosis? And the answer is that several of us believe that you shouldn't have to for primary otosclerosis, but the lawyers are forcing us into doing so. And that's the short answer.
Yeah, I think we do. Yeah. We always do it because we want to be sure that we don't have any other. Wenn Sie noch ein bisschen kleiner, wir suchen mal, ob es geht. So it's just a bit of shale form for basically avoiding some bleeding. Bitte kleiner, die Hälfte davon.
So actually, we've just put a question out on the poll on Zoom regarding the CT scanning prior to surgery, and the majority of people said that they would actually perform a CT scan. 59% said they would.
Yeah, but
just
you can
the majority.
Do it in former times we did just an X-ray. You can, of course, make the cone beam CT, which is a low radiation dose, should not be harmful for the patient. So now actually we go for the cutting, and
that was an epinephrine. Was that an epinephrine pledging you just put in, or gel foam with epinephrine?
Epinephrine, yes, and some local anesthesia, just to let's say add additional anesthesia, which might be helpful. Okay, bitte mal den. Yeah. So now we have here the prosthesis. You see, it's a old-fashioned platinum wire Teflon. And so recently, I think Dr. Teschner, he found an interesting thing in one patient with for revision with a titanium prosthesis. So perhaps you can comment on that. Dr. Teschner. Ja, das ist 0.4. Können Sie mir die 0.6 geben, bitte?
Can you hear me?
0.6, ja.
Yes, I can hear you.
0.6 haben Sie?
Okay, so this is Magnus Teschner speaking. I found an osseointegrated titanium prosthesis in a revision surgery. So the titanium prosthesis was completely fixed in the oval window with some new bone, and I had big issues to remove the bone. So I think that is an issue with these prostheses, with these kind of prostheses we should be aware of. So I, for me, prefer to use platinum Teflon prosthesis instead of titanium prosthesis. Do you see this?
I think what we
issues
can
as
say
well?
is that since John Shea put the first one in 1956, some people have used prostheses with a Teflon distal tip at least ever since, and it stood the test of time. It's a good material.
Yeah, the Teflon is right, but the titanium is the issue. The titanium prosthesis.
Yes, that's what I was saying. Yeah.
Okay.
Thomas,
How
if you
often
don't
do you,
mind, I would like to see how the progression is in France, and we'll be back with you as soon as we can. Okay. Professor Leonard.
Yeah, of course. No.
Hello, Robert.
Hello, back with you. Good.
Yes.
So I'm going to perform now the stapedotomy. I'm using again the laser just for the first shot. 3 watts, hein? And you see only one shot is enough sometime, or I can use another one. That's it. And now I will perform the stapedotomy. The other option would be to do a laser stapedotomy, but in that case, I would have to increase the setting, which I don't like too much because I'm always frightened about heating the labyrinth. I'm trying to move a little bit the camera so you have a better view, not embedding the picture. I think it's fine for you now. And again, I'm using the 0.7 millimeter burr, diameter burr, to perform the stapedotomy. So you notice that I'm using also my left hand with the sucker, which is a 0.7 millimeter diameter sucker. And I'm controlling the fluid leakage with the suck while I'm just leaving the diamond dust doing the job by itself. And now it's done. You can see the fluid coming up. And now I'm using the micro drill to finalize the stapedotomy now.
So Dr. Vonson, we've just had a question on the Zoom about using manual perforators rather than mosquito drill. Do you have any thoughts on this?
I never use a perforator. I always use the micro drill because I think it's more safe. It's safer than a perforator, especially when you have a very thick foot plate. Well, it's interesting point. You can see now I did not perform a very perfect stapedotomy. We have some residual posterior part of a foot plate. You can see it, right? But I will not remove that. I will, because it's enough. Now the shaft will go into the gap between the anterior part of a stapedotomy and this residual part of a foot plate. If I want to remove it, there's a risk that I push it into the labyrinth. So it's better to leave it. And then just cover it with the vein. Okay, and that will be enough for the prosthesis. Okay, so let's now
this is
place
good, Robert,
the vein
because
over.
this is proper live surgery rather than
Yes,
canned video, and it proves some of the problems you can have. What I would comment is that your anesthetic field, or the anaesthetist, is giving you a fantastic field with no bleeding. Just quickly before we go back to Hanover, could you ask her what or him what the blood pressure is?
The blood pressure is 99. 30. C'est quoi la pression? Combien? Yeah, it's 60 and 30, which is pretty low.
Well, that's incredible. It just proves that every otologist is only as good as their anaesthetist.
Oh,
I shall wait for my awards from the anaesthetist there.
So I'm introducing the vein graft, and maybe then you can move to, I have a problem with the sucker, but anyway, I'm introducing the vein into the middle ear, into the oval window with the sucker, and just stretch the vein with the needle like this, and that's enough. And then maybe I can wait. You can go back to Hanover and wait for the piston if you want.
Yes, I think we need to check because I think they're going quite parallel. We'll be with you in a minute, okay, Robert? Bye-bye. Hanover,
so
we're
just,
moving back
yeah.
to you.
Okay. Yeah, I have
Okay.
just cut the posterior cruise with the drill. And now I go for the foot plate. So we open it also using the drill. In the kleinsten Sauger. Can you hear me? Yeah.
Yes, no problem.
Yeah,
no
Thomas,
problem.
we can.
Okay,
We were just
good.
talking about
Then-
good fields, and you've got a good field as well. Would you ask your anaesthetist what the blood pressure is?
The blood pressure, ich kann fragen, der Blutdruck dabei, die Frage wieder hoch, wie hoch der jetzt ist. 88 mercury.
Good. So again, that's a nice low hypotension, which is good.
So now we try to open the foot plate an 0.6 draw. So perhaps you have some. There was some fluid from the previous irrigation. And it's not that open. So there was a question with the perforator. I think now I have it perforated. You see some dust from the drill. And I try to, now we have the opening. I think you can see it nicely.
Yeah, it's a great view.
And now we have to cut the anterior cruise. So I need a hook, bitte ein 0,6er.
So Thomas, you don't normally use a laser, you just use the micro drill. Is that correct?
Yeah, we use also laser in some cases, but normally I think it's okay if you just go with the drill. It has some disadvantages with the drill, I know, but the point with the laser is that it's more work for preparation, yeah, so that you can use it. That's perhaps one thing, and might be more expensive. Bitte mal das Häkchen, yeah. So now you have to go through the tendon here, through the joint. Sorry, and here is, or I think the anterior is already cracked. So you have to find the joint now here that we can open it. Robert did it before he went into the foot plate. I do it now. Also, we can debate about it.
Well, I think it's a very interesting point that we can discuss once you finish the procedure, because I think it's quite opportune. Makes difference.
Yeah. So, John, you were talking about the laser before. I mean, I remember working. Sorry, Professor. I remember when I was working with you.
So basically, you can bend it out now and then try to cut it. It seems to be a bit more difficult. You see, Robert has a very elegant technique. Here, a bit more. Bitte ein Zingelchen, ein kleines. So now I think we have probably done most of it. Bit of the bone dust there. I try to take it out. You can also leave it in. Haben Sie ein feines, bitte? And then we can put in the prosthesis. So I hope we can get it out here. The quarter is always in your way. That would we say, und das Singelchen ist sehr, sehr schwer. Well, I think I
Wilco,
have
should we go
lost
back
it,
to Robert
the
and watch him
superstructure.
put the piston in, and
down
then
there.
come back to Thomas to watch him put the piston in?
Das ist sehr, sehr schwergängig. Oh, mein
I think I can see Robert is waiting, and I think
it's not working.
let's because
I think the small forceps is going too hard. So bitte nochmal das andere, die eine größer bitte.
John, I think Robert will
you know,
excuse us that we stay a little bit with Thomas because he has the inner
Okay.
ear open.
Yeah, you
and
go just to him, please. No?
we stay with you, Thomas, and
We'll stay
Robert
with
has,
Thomas. We'll stay with you.
Robert has it sealed with the vein graft, so we'll go to him in a minute.
Okay.
So now I have the superstructure removed. Das können Sie wieder abnehmen und das Zängelchen sauber machen. So, okay, now we have a bit of bone dust still left in there. Wieder mal das Häkchen 0,6. And Robert has, he uses a vein graft. Well, there's a question, is it good? I think yes, but I always would like to see where my piston is going to. So now I think basically we have cleared it down there. And then we can place the piston.
Yes.
I think an important point to make at this stage for the audience, particularly the younger consultants and specialists, is 1 or 2 minutes spent at this stage getting everything perfect can make all the difference between a bad result and a good result. And you'll notice that both of these surgeons are being fastidious in making sure that bone dust is removed and any tissue tethering the incus is removed, and that they've got a perfect view. These are all little things, but they make the difference between a 70% success rate and an 80% success rate, or in the case of these two, over 90%.
John, can I just comment there?
Yes.
Once you've opened, once you've made your stapedotomy, though, is there sort of a time limit, or is it prudent to perhaps, you know, not leave it open too long?
Well, there are a couple of risks here, Nina. Both of which are important. I mean, the first of which is you don't want to get a dry labyrinth. You don't want to accidentally suck anywhere near the stapedotomy.
No.
Because
John,
I
think it's a very good question, but to allow the procedure to go on,
Yeah.
I think we should allow Professor Leonards to explain his prosthesis. And I think the question is very valid. Let's take it to the next to the end.
Yeah, we just checks the opening, whether it's wide enough with a kind of measuring rod. And now I bring down the prosthesis, which probably is also 0.4 millimeter. And you see here now that we probably, I still have to correct the angle for insertion. Das Licht bitte weglassen. So now we can try to move it in. So we position it. Now we need the needle. Even though it's a straight view to the foot blade, I still have the tough tissue in my way. And I have to bring it down, so sometimes you can make it in one straightforward movement. It's kind of a bit more difficult. because I have hooked it here in the soft tissue. So that's my problem. I need some time to get rid of it. Here you see it's basically kind of hooked in here, which can be sometimes difficult. So I need some patience to do it. It is Häkchen 0,6. So yeah, it's
we all know this moment.
so the prosthesis disappears, no?
Thomas, we all know this moment. This is
Yeah. You see, it's not mastering. It's just try to. Some people would like to have another prosthesis for this moment, but as we explained, we stay with this old-fashioned thing. And now a bit Nadel, bitte. So we move it forward.
I think the important thing for the people watching is at this moment, what you must do is just slow down, breathe gently, because you know you can do it. If you get your adrenaline going, it makes life very difficult. But it's obviously very difficult to operate live.
Hey, McGee, bitte, das ist kein McGee. So I hope that I can.
It's not these surgeons who've
So
done
das Ding ist auch
so
haben Sie noch was anderes machen? Die gehen alle so schwer, das ist furchtbar. So now I still have to close it. Ich brauche einen anderen McGee, sorry, tut mir leid, das geht so nicht. Sorry, this instrument is not well, so to say, it's not well oiled, as we say. It's kind of too hard. I have not the control over it.
it's sterilized too many times. Yeah.
Yeah. You know, with all centralization.
Yeah, we know the problem.
It's always the same problem you have with bureaucrats. And
It's going out live on the internet, Professor Leonards.
No, it's not. I can't use it. Sorry. Nadel. Ich brauche einen anderen McGee, bitte. Ne?
It's very difficult for the viewers to understand the procedure or the small size of it if you have never done it, because these are critical steps which require the utmost control of breathing, etc., etc. For some, not for all.
I think the other important point at this stage is Thomas has given himself a very good exposure with his removal of the rim, the scooter, which means he has actually got plenty of room to get the crimper in. Although it's not the best crimper, he's able to get it in nicely.
I think
that's very good. That's a bit like the three teddy bears and the porridge. Not too much, not too little, just right.
Yeah. You said I want to avoid to overpressure it, no?
To avoid erosion. Any final words, Thomas? Otherwise, we need to go to Béziers.
Thank you for your patience, and sorry I was not the best case done, but I think it showed some difficulties. Now it moves very well. As when
Yes.
I touch,
Good.
you see the
That's good.
values,
Yeah, that looks really good.
and it should be okay.
And there's
Should be
no
okay.
I thought
need
that
to
was great, Thomas.
apologize at all.
This
Yeah.
is real surgery, Thomas. This is great demonstration. Thank you very much.
Okay, we need to go quickly to France because they're waiting. All right, Robert, we're back with you. Sorry about
Okay,
that, but
that-
we
no
I
problem.
think the demonstration is fantastic because we see the difference in technique. It's really marvelous.
So I'm using this cost piston, which is made in Teflon. I cut it at 4. This is on a cutting block. And I'm going now to open up the loop to break the memory of the Teflon like this. There we go. And now I'm going to place it into the middle here. And I use a different technique than Thomas. I use a sucker to introduce the prosthesis within the field. So I'm going to grab now the piston and introducing with the sucker, trying to place the shaft into the field like this, goes into the oval window, and then placing the loop around the incus. There we go. And now I just need to crimp it. And now check for the bending sign. So we can use the curve forceps, but also we can use this trick, which is a little bit more tricky, of course, than the curve forceps. But when we have a narrow gap, like in my case, I think this trick is good. So 2 hooks, one is used to stabilize the posterior part of a loop, the left one, and the right one is to close the loop. There we go. And I'm going to look for the bending sign to be sure that the shaft is located into the labyrinth. So let me see what we have. The bending sign, just to be sure that the shaft is into the labyrinth. It's clear that if you use a Thomas technique, you can be sure by vision. You cannot do that with a vein graft. So I'm just stretching it, the vein like this, and then looking for the bending sign. The piston should bend like this, but not move. And if it's too short, then you can see when you are doing this, that the piston is clearly moving away from the other window. So it's fine, and the
Robert,
movement now
I think
from
your
the mallet is
closing
fine.
of the I think your closing of the piston with the 2 hooks is very elegant. I'm probably not out of order saying that you'd probably agree that that's not a technique for a new state B surgeon to use in their first 100 or so cases.
Yeah, you
it
need
requires
to train yourself.
extreme control of the hooks.
Yes, that's true. But you know, it's a very good one in case of narrow gap between the malleus and the incus, where in this specific case where you cannot use the curve forceps because the gap is too narrow. So that in that case, the technique of the 2 hooks is really nice. But now I use it all the time because I prefer. But it's true, it's not an easy one. It's true.
And John,
the other thing that I comment between the 2 surgeons is that neither of them went terribly tight with the crimping of the prosthesis, and I think that's probably important.
Robert, can you explain how you're closing what you do? Because you have just 1 incision, and what do you do now?
I just put a plug, which is the Merocell, into the external auditory canal and put some solution in it of betadine and then of fluoxetine, and then I remove this plug on the 5th day. And I check the bone conduction just before they leave. That's my point. I know it's much longer than anywhere else, but I think it makes the difference in terms of post-op, time for the patient, in terms of dizziness and things like that, and also for the post-op hearing outcomes. I really believe it's not only the surgical gesture, but also the post-operative care. And after a few days, I think it's better to ask them to leave. Yeah. And then I said, I see
Robert,
them after 3 months.
I think staying in the south of France in the sunshine for 1 week is not a great hardship. We'll join Chris Aldrin soon, and I probably wouldn't want to stay in Slough for a week. We'll see what Chris thinks about. They're just asking, what is the diameter of your prosthesis?
My prosthesis is the same as Thomas, 0.4 millimeter diameter.
Okay, so a 0.6 hole, 0.7 hole, and
look, it depends. It depends if you do. It depends also if you do interposition or not. Because for those, usually not like Thomas, but usually some people who do without interposition, they use 0.8 millimeter staphotomy using a 0.7 millimeter burr, and they put the piston, but the piston is 0.6 millimeter diameter. It's a little bit bigger, usually.
Okay, do you give antibiotic cover?
No, not anymore. We did that in the past, but now since many years, I do only one shot of steroids, and that's it.
Okay.
There's been I was going to say, there's also been a brief question about the measurer that you use. Can you just tell us which type it was and what the intervals were, please, Dr. Vonson?
What? Say it again.
Just about the measuring rod that you use to measure the prosthesis length.
Yeah. Well, that is the Stapis measuring rod. You notice that there are 3 hooks like this.
Yep.
So the lower one is 4 millimeter. The mid one is 4 millimeter. Sorry, 3.5, 4, 4.5. So you just put the distal tip of the measuring device in contact with the foot plate, and then you check which of the 3 notch is becoming in front of the incus. So if it's this one, like in my case, it's 4 millimeter.
Okay.
Brilliant. That was for one of our viewers on Zoom. Thank you.
Thank you.
Okay.
Thank you
we
very
go
much.
back to the studio because we have some questions.
We should welcome Core as well. I see he's appeared with a.
Okay.
Hello, Core. Hi.
Hi.
That tie will certainly brighten up proceedings.
It's good. It's a good tie. Yeah.
There was a question there, Wilco, about bone dust. About any concerns about bone dust going into the labyrinth. I don't know what your views are on that.
My views. Hold on. You mean this question from Maymet?
Yes. Yes.
Well, I think it was very clear that Professor Leonard took immaculate care of cleaning. I think if you leave, you're typing, John. If you type, please mute your microphone. I think if it's not too much, it's not a big issue, but we saw Professor Leonard clean it very extensively. So I think that's good. Not a big issue, I think. We will go.
I know that Robert, until recently, I don't know whether he still does, still washes his gloves, even though they're powderless gloves, because he believes he should try and keep every fragment of dust, bone dust, dirt, everything away. There's another question about the endoscopic approach from Mehmet Karatas, and I think myself and Robert have made it clear that we don't favour the endoscope. We're probably a bit too far on in our careers to adapt the technique. But one of the points that Robert made was that you have 2 hands if you don't use an endoscope. You only have 1 hand with the endoscope. And the other thing is that we can't understand, but maybe the endoscopist will explain to us over the next couple of days, is you make as big a hole with the endoscope as you do performing a posterior, lifting the drum up.
John,
it doesn't make much difference. Yeah,
I'm not sure if Hanover is still connected. Of course, they're connected because
they're putting the packs in. Yeah,
yeah, they put stylistic sheeting in. I think is that the case?
Yes,
Thomas.
Yeah, we just wanted to show what we did is you see we have put in some. Let me check. Perhaps you have seen it before. So we did. We put some blood to close the inner ear.
Yes. Yeah, that's clear.
Freshly taken blood. Yeah, that's down here. You see it now?
Yeah, it's very clear. A blood patch. Yeah.
Yeah, blood patch. No. So it's natural glue, and then here's our cut in the cameatus. Now put on this stylistic, just to give some good healing, and then we put on some you see this Merocel or so, Merocel tamponate gel foam.
Yeah, gel foam. It's resorbable, I think.
It could, yeah, but it's external, so it won't be resolved. Okay. And then leave it for 5 days, and then it's removed. No.
Okay.
So that's basically our closure.
Yeah.
It's also transmeatal. We also use transmeatal approach, so we don't need a suture at all. And
okay. Cool.
Oh, that's it, you see.
Thank you, Thomas. We will be back with you because you have a full program. As people can see, the program can be downloaded from the internet. And I propose to see what Chris Alden is doing, because I know he's there.
Hi. Good morning. Good morning, Wilco.
Hi, good morning, Chris.
Hi.
Cor Kramer says hi as well. He's here.
Hi, Cor, and hi to John and Nina and to Robert and
Good
Thomas
morning.
and everyone else listening. It's very nice to be with you all. And Joachim. Hi. So I'm sorry we are a little bit late, but as you can see, we have a patient on the table. I hope you've got a reasonable image. We're going to zoom in a bit. And
speculum holder as well.
Yeah, so I use a Yazagil speculum holder. This is Yazagil, who was the neurosurgeon who worked with Ugo Fisch in Zurich. Ugo Fisch, for the younger surgeon, one of the world's most famous skull-based surgeons and otologists. And Yazagil was his neurosurgeon, and he came up with very nice articulated arms. So it's a series of little metal pieces, tubes with balls between them, and there's a wire that goes down the middle, and you can tension the wire, and that allows you to tighten the arm, but you can put it in a variety of different positions. So I'm just going to inject now. So what I do is I pull my speculum out a little bit, just so I can see the hair-bearing skin, and then I'm going to put my needle through that skin, and then gently just inject adrenaline. Now, I don't use any local anesthetic. I just use the adrenaline. I'm just going to suck a little bit of fluid down the canal there. And I've got my assistant with me, Ellie, today. And Ellie, what I want you to do is keep your eye on that image. In fact, if you go to the screen, Ellie, and touch the middle of the image, that's good. And what you have to do, Ellie, is tell me if I'm going off screen. So if you can't see what I'm doing, you just tell me. And that's also the same for you, Nina. And do you see that? Now, I just got a bit of a bleb there. And interestingly, the blebs normally occur when you go supra. You don't normally get them down there, but this is lion, and therefore you have to expect the unexpected. But that's fine.
With John and all.
Yeah.
Mr. Aldrin, can I just ask why your preference is adrenaline alone rather than a mixture of local anaesthetic and adrenaline? Is there a reason why you do that?
Yeah, well, of course there's a reason, Nina. Of course there's a reason. Let's just bring a bit of light. So when I was a baby doctor, I remember doing a moringoplasty in Newcastle, and the patient woke up with a facial palsy. And I said to my boss, I haven't been anywhere near the facial nerve, but of course it was from the local anaesthetic. And then, you sit and you wait, you sort of know that you've done nothing wrong, but you're worried about it. And actually, the lignocaine we're okay. We don't need that. We switch that light on. I just don't think they really need it. This is not particularly painful surgery. So we're going to take a bit of vein now. So that's why I don't use it. And I don't use it on any ear surgery. I don't use any local anesthetic. Just for that reason. So that if they wake up with a facial palsy, God forbid, then I know it's my fault.
And if you asked every otologist listening what the first thing they said to a patient was post-operatively after an ear operation, I'd be prepared to put big money on it being give me a smile or clench your teeth. And you've had a great, although
and if they can't do that,
we rarely get facial palsies. It still worries you at the back of your mind, doesn't it?
Yeah, of course it does. Of course it does. So that's why I don't do it. So I think they don't really need it much. Yeah, go on.
We all know it's not so easy when John is with his surgical suit on coming to your room to smile, to tell you honestly, that would put me off quite a bit, John.
Yeah, no, for sure.
Chris, we don't listen to Dutch. Chris, we notice you're using a transcanal approach as well. You and I see benefits to that, and Robert does. Would you like to describe your experience at that? I don't know whether you were listening to the conversation that went on about 20 minutes ago, but how many have you done, and how often have you had to I never do an incision. I mean, of all the ones I've done one incision, and that was years and years ago. I never do an incision. You can always do it. You can do it through the tiniest of speculum. And the advantage is, I do so much surgery through the canal. My aciculoplasties, I do lots of athecotomies, cholesteatoma work, just through a transcanal approach. The advantage is no incision. They don't get a numb pinna. The other advantage, particularly for stapes surgery, is there's no bleeding from an endoral incision running down to obscure your view.
also the speculum itself takes the hair-bearing skin out of the way. So my personal feeling is you get a better view with a per canal using a speculum than you do using endoral. But obviously, you know, a lot of people would contest that, and that's one of the great things about Lion.
I would agree entirely with that. You've summarised that beautifully. Could you sharpen the focus just a little bit, Chris? Just a little bit.
Yeah, let me try that. Just hang on a second. Ellie, can you come here for me? Can you just turn that to -1.5? Turn towards you. And this one as well. 1.5. Try that. See if that makes any difference. I don't think it will. Okay.
So, Chris,
don't worry, because it's not a big deal.
Is that any better?
Yes,
it's a little bit better.
better.
Yeah.
Well, you can't ask John with it more.
That's better. That's perfect.
That's better, yeah.
That's better.
That's good.
But Chris,
Good. Okay, thanks. Yeah, keep me right with that. Yeah.
Chris, do you ever do a laryngoplasty retroauricular, or do you do all laryngoplasties also via?
I pretty much do all of them via the canal now. Yes, thanks, Rosie. Pretty much all via the canal.
That means there are exceptions.
There are exceptions, and the exceptions are when there's a very anterior perforation. But I have to say now, with those, I tend to use an endoscope to help me. So it's pretty rare that I go retroauricular. I mean, obviously I do for cholesteatoma. You know, if there's a big cholesteatoma down into the mastoid, of course I'm going to go retroauricular for that. Thanks, Rosie. Can you just take the clip? So yeah, I mean, there's a place for it, but I mean, I never ever do an incision for stapes.
No,
and
but
very rarely for laryngoplasty, very rarely for auriculoplasty.
Actually, no, I do endorals, not for stapes anymore, but I do them for, say, an anterior perforation. And then it's a good way to avoid maybe retroauricular, although it's not fully comparable. But I think it's a good in between procedure. Yeah.
Okay, that's interesting. I mean, obviously, that's the great thing about this is get different opinions. Yeah.
What was the ligature material you used there? What was the ligature?
So I use Vicryl Rapide. Yeah. I used to use Vicryl, but when they come and see you, sometimes they have a little mark. You know, they have a little bit of swelling here. And so I use Vicryl Rapide.
They complain more of the lump on the back of their hand than every other symptom. Yeah.
And I always say to them beforehand,
linen, and that was fine. You'd have expected that would have caused irritation. Yeah. But it didn't. But it was withdrawal.
Oh, that's interesting.
So that's a single suture. So that's nice. That's nice.
So it's a single suture, and we put a little steri-strip on it, and then we go back to the ear. And what I normally do now is I raise the canal flap down to the drum. And then I go and prepare my vein whilst I leave a little bit of a drain. You'll see, we'll do that. Yeah, okay. The other thing I do with the anterior perforations down the canal is I drill off the anterior canal wall. Robert does that quite a bit. So again, that allows you to do it orally, and that allows you to sort of inspect the ear a little bit better post-operatively. Let's just have a brown sucker now, please. So we've got different coloured suckers with different diameters. Yeah. You can call me Chris, please, Nina.
Chris, we've already had this discussion with Dr. Bonsant and Professor Lennart, but about preoperative CT scanning. Do you have any views on this? Do you scan?
Yeah, I scan everybody. Yeah, and the reason I do that is years ago, I did a stapedectomy on a guy, and you know, it all went fine, and I was quite happy with the surgery. And I saw him post-op, and said, "How are things going?" And he said, "Well, no different really." And he still had an airborne gap. And at surgery, it was one of these ones where, and the guys will tell you this, occasionally you come across where you sort of think, "Oh, I think it's probably fixed." It feels a little bit fixed. And that was one. And when we then scanned him to see, and the prosthesis was beautifully in place, but he had superior semicircular canal dehiscence, and I'd missed it. And I bitterly regretted that. So I always do a scan now, just for those rare conditions that mimic, and that's the main one. But also, if they've got a fixed malleus, it's quite nice to know that. If you go into the ear and you sort of expect them to have a fixed malleus rather than a fixed stapes, it's quite a good thing to know about. Yeah. So I'm just using this knife that we use here is a disposable blade. It's nice and sharp, particularly when you do something silly like raise a bleb. if you've got a blunt knife, you end up ripping the skin. And this is really quite sharp. So can I have a spud now?
Chris, just tell us a bit more
Yeah.
about that blade, because it's made a huge difference to my practice, and I got the tip from you. So if you could
Yeah,
just tell everybody
it's
about
made
that
by
blade.
Invitec. There's a handle that comes with it, and the blades are disposable, and you can get them in different angles. I usually have that angled one like that, and then if I want to change it, I bend it with a pair of with some artery clips, and you can change its angle, which can be useful. I haven't actually changed it here, but I quite often do. You'll probably see I will on some of the other cases. And then we're just raising the skin, and the trick here is to push the skin hard onto the bone. So you're basically pushing down onto the bone, and then the skin sort of strips off, really. Hopefully. Let me have that Invitec blade, the disposable blade again, please. Take that. So we're back onto the... Yeah, go on.
There's a question just come through, Chris, about how much of the scutum should be removed, and I'll just answer that. One of the things that Robert tried to show was that you remove enough bone that you can see certain landmarks.
Spud.
And the answer is, ideally, you want to see about half of the long process of the incus. You want to see the stapedius tendon at its full length, and you want to see the facial nerve. So you remove enough scutum to see those three landmarks. If you do that, you'll have enough room to work on the incustapedial joint and the posterior crus. And you'll also, if you use a crimper, have enough room to get your crimper in at the end of the procedure. Because one of the most frustrating things is not to remove enough bone and then not be able to get the crimper in.
So
Chris
will
will
adrenaline there.
show us the landmarks when he gets to that stage.
John,
Yeah.
to tell you honestly, I think in revision surgery, and I'm here with Cor Kramers, maybe he can confirm this. Revision surgery, I always encountered that the exposure, to my opinion, was inferior in many of the cases of the revision. Cor, what's your opinion about that?
Yeah.
Exposure is very, very essential for performing well this type of stapedotomies.
But you would both agree that it's important to too much superiorly, because then the drum drapes onto the incus, and you definitely don't want that.
Yes, that's true.
So I think, particularly when you're starting, giving yourself more space just makes the procedure easier. When you're demonstrating it as well, it's really nice to have a decent exposure, because you get a better view, you get more light down there, and people can see more easily what's going on. Let me just try and get that. Okay, so this is our vein. You can see a little bit of fat on it, and we put in a bit of saline, and then you find that it opens the lumen up. It makes it a bit easier to find. And then I just thread it on this needle. The needle gets wider, so as you thread it up, the vein sort of stretches. And then you get your assistant just to gently hold the ends of this for you. And then you just gently hold the adventitia here, and you pull it towards you, and then you start cutting. And as you cut, usually, sorry,
just off screen.
Yeah, thanks. Just keep me right on that.
It's like pulling paper off a toilet roll, isn't it? Although in these COVID
John, please
crises,
keep the level up, please.
Well, you know, that was a very important issue in the early days of COVID.
Okay, here we go. Sorry, yeah. So yeah, you're right, John. It's like pulling. I've never thought of it like that before, but it is like pulling. I've got some horrible images in my mind now of you sitting on the loo. And they're sort of confused with the Dulux dog. Okay, so here we go. So this is the vein. It's stretched over the needle, and I'm just gently so I rest the knife against my finger, and then you just roll the knife along and cut. If you don't have it on your finger, it's very easy to slide off this needle. And we were talking about size before and how small it is. This is just my finger here. So you can see it's all pretty small stuff. Now that vein graft is way too big, so I'm going to trim it down. And for this, you want to roll in.
It's great to have a spare bit, isn't it? You know, quite often you get a little weakness in a drum or a tear.
In John's case,
that's the other thing we were talking about. Bone removal.
Yes.
Yeah. No, we were talking about bone removal. You'll also find that, you know, some less experienced surgeons remove so much bone, the drum then won't stretch. And to have a little bit of spare vein then may be useful.
So then I make a little dimple in the middle. This is just a little fine sucker tip. Okay. And that should hopefully go into our stapedotomy. So now we're going back to the ear, and hopefully the adrenaline will have done its stuff. So that little bleb that I made, because we have that nice sharp knife, it didn't really matter that much, I hope. Okay, so we're going to go onto the crocodile forceps now, please, Rosie. So I have Rosie with me today. My anaesthetist is Claire Rock, and the anaesthetist Roke, sorry, and the anaesthetist is really crucial for ear surgery. You know, you really want someone who can reliably give you a nice hypotensive anesthetic. Okay, so if I can have the spud again.
We got the pressure from the other two. We got the pressure from the other two in the German approach and the French approach. What,
yeah.
Claire, tell us what the pressure is with this patient?
So the pressure of this, we got a systolic of 83, which is just about perfect, really. As you often say, perfect. You really want your systolic about the same as the pre-op diastolic.
Resting diastolic, yeah.
Resting,
but,
yeah, pre-op resting.
That's for ASA 1 and 2 patients.
Yeah. Well, this is a 36-year-old.
You don't want to do that in the old Crocs. Yeah.
Okay. So now I've got a headset on, so in theatre they can hear what I'm saying, but they can't hear what you say, John. Okay. But I will relay it to them. So you can see the annulus here, and just get underneath the annulus and just gently lift that forwards, and then you should just drop into the middle ear there. You can just see chorda coming into view underneath, I think. There we go. So there's middle ear now. Just raise inferiorly. And then flip.
Can I just add a comment? Actually, I've just put a poll out on the Zoom group as to what the preferred surgical approach is for stapes surgery, and it's pretty close actually between transcanal and endoral. Transcanal was 58% and endoral was 42%.
Nina,
I'm not sure.
I don't know if it's put. Can I just ask if you could slightly turn the volume down on your microphone, because you're much louder than the others.
Course.
So whilst it's lovely to hear you, you're suddenly shouting in my ear.
Apologies.
No, it's fine. It's fine. It just needs balancing a little bit.
I've just done that. Is it any better?
That is better. That is a bit better.
To tell you honestly, Chris. I get complaints for my volume and John's, and that Nina is the only one with a good volume on the.
Well, I mean that's fine. You can do it the other way around. I don't mind, but they just need to be a little bit balanced, because I've got headphones on and suddenly it's really loud. Okay. I think that question you asked, Nina, depends where you ask it. So if you go into Europe, a lot of people do endoral incisions, and if you stay in the UK, it's probably more doing percanal. Okay, so now can I have a curette, please? So actually, just give me a needle. I'll just point out the various bits. A slightly curved needle. So what we can see here, I'm just going to slightly more center the image for. The problem with this microscope. It's a Leica microscope, but the ceiling mount doesn't really hold it still. So when you let go, it moves a bit, which is fine once you know about it. You see it swinging around a bit as I let go. Okay, so we can see this is chorda here. So I'm just dividing a few little adhesions above it. There's the chorda. This is the incus. Looks mobile to me. And there's the stapes. And the stapes is definitely fixed. You can feel that quite clearly. A few little adhesions here.
And a nice view of the round window as well, Chris.
Very nice view of the round window. And then this bone here needs to go. That's quite thin by the look of it. So if I can do a curette, please, Rosie. You should change just slightly. Yeah.
I spent all these years telling everybody to get a ceiling mounted microscope, and you were obviously having problems with it.
Yeah, no, it's interesting. It's not new anymore, but when they came to fit it, I mean, I love the optics of it. I think it's a nice microscope. But when they came to fit it, we found it just wobbled around. And even when we closed the door to the operating theatre, it moved. And so I said, well, that's no good. Can I have the heady hook, please? Sorry, I'm just coming off.
That was the hospital engineers not putting an adequate infrastructure.
It might be that. It might be that. Yeah. But
we had to have 3 RSJs put in to do it, and it doesn't move at all.
Yeah. It might be that. But it's interesting because I had another Leica microscope before, and it didn't do it. And then we ended up having to change the doors on theatre to make them slow soft closing doors, because as they closed, everything would move, and you're just about to put a stapes prosthesis in with the world watching. Someone would slam the door and the whole thing would move. So it was bad. So we're just gently dissecting out the chorda here. Yeah, go on.
Getting a great view of the chorda. So you're putting a hook in the chorda canal there to
yeah, this is something from, they told me about Bézier from the Micro France group of instrument makers, that this is what Benoit Grattacap, who's a super chronic ear surgeon in Béziers, used to use this one, and you just put it into the canal, and you can use it almost like a tiny curette, but it's just small enough to get into that canal. Okay, just give me a needle.
Chris, is your preference always the curette and the hook rather than using a drill?
Yeah, it is actually, Nina. I mean, Wilco used to use, I don't know if he still does, but he used to use hammer and gouge with great effect. But I do tend to use the curette. I'm not honestly sure that a drill's a bad thing, and it's certainly quick. I don't worry so much about bone dust. What I worry a little bit about is irrigation fluid from the drill being somewhere in the middle ear, and just when you do that stapedotomy, a big blob of it runs down, and then it's right in your way. And you know, we saw and I thought Thomas did it brilliantly, but we saw with Thomas it was bleeding a bit when there was a stapedotomy open, and you really don't want that if you can avoid it. And you don't want irrigation fluid from your drill. Can I have the curette, please? Coming down just as you're about to do your stapedotomy.
Yeah, that's a good point.
So yeah, so I'm just going to take a little bit more. I've got a nice view of the incus. I just want to see a little bit more of the back of the drum. The thing about curettes, and John will tell you this as well, you need sharp curettes. And years ago, I did one of these lion things, and I happened to have the world's bluntest curette. And as luck would have it, it needed masses of bone removing, and it literally, I think it took me 20 minutes to get the bone out. It was very, very slow and annoying. Okay, let me have a needle now, please.
I think the
So
other
let's
thing,
see
Chris,
what sort of view you've got. Yeah.
When you first pick up a curette as a trainee, whether you like it or not, you haven't developed the thenar muscles for taking bone off. You need to practice
again?
using a squash ball for months to build up those muscles, and then it becomes much easier.
And
yeah, it is a funny thing, isn't it? Because I mean, people who don't know me, I'm quite little, and you know, you get trainees who are sort of big guys come in, and they just cannot curette. And you say, "Oh, just give me the curette," and then suddenly you're taking, you know, big shards of bone off. But it's exactly as you say. I think it is a bit muscle, but it's probably more technique than anything else.
Technique.
Okay, let me have the green second now. The sharp curette makes such a difference, and I you know, whenever I do these things, I say to Clara, who's our sister, or Rosie, who's assisting me at the moment, "Have we got a nice sharp curette for Lion?" And they save up and get me one specially.
They only find one, probably. But anyway,
well, that is a problem. Yeah, let's have a brown again.
I still use the gouge, and I know Cor used to use the gouge. Yeah.
A needle, please. Yeah, I think in the right hands it's really good. The first person I ever saw do this operation was Tony Bull, who was a needle, please, was a famous rhinoplasty surgeon in the UK, but also did a mean stapedotomy. He was very good at stapes surgery, and he used a hammer and gouge, and it was certainly very efficient. You know, it was quick. Okay, so now I think we're in a position, we've got a nice view of the foot plate. We can see the pyramid, we can see the facial nerve, we can see the incus. It's a nice view. So we're going to divide the joint now. So if I can have the joint knife. Okay. So as Robert showed you, you can stabilize the incus with your sucker, and then the joint is always a bit more medial than you think when you first start off. And unfortunately, sometimes it really just, it isn't a beautiful joint, you know, there's sort of, there we go. It was a bit more medial than I thought then. There's a sort of bit of funny tissue on the back of it. We don't want to dislocate the incus. If we dislocate the stapes, not the end of the world because we're taking it out, but to dislocate the incus is a pain. So we're definitely through that. There's our stapes. Incus definitely mobile. Okay, so we're going to have the laser now. So we're going to have the laser on. We'll have it on So we use an iridex laser, which I thought was a diode, but I gather it's actually a KTT laser with a diode aiming beam. It's an iridex Ocuflex, and we use it on 1 watt on a continuous setting when we start off. And we're just going to laser away the stapes. So we're going to start off with the stapedius tendon. Okay. 1,000 and 3,000. So 3,000 is 3 seconds, 3,000 milliseconds. 1,000 is 1,000 milliwatts. So a watt. And what I like about this laser is it's got a beautiful autoprobe. John designed an autoprobe, which is pretty good, but this one is really nice. It's a little bit better than that. You don't have to thread anything, it all comes. So are we ready, guys? Have we all got our glasses on? Now, I've got a filter on my eyepiece. There isn't a filter on the camera, so if you have epilepsy, look away at this point. Can we have the laser on, please? So this is stapedius tendon, and we're just going to laser through that. There we go. So that's good. We're through there now, and then we're going to come the other side of the corda, and we're going to laser the posterior crus.
Actually, I have to say that is a very nice endoautoprobe you're using. It's very fine, isn't it?
It is. It's super. Just really doesn't get. If you looked at the one that Robert used, it really sort of obscures your view because the probe's so much thicker, and this one really you can see around it. Just taking these few little adhesions here.
But that's actually quite a convincing division of the crus. I mean, remember the crus is.
Yeah, we're right through it, aren't we? Look.
You can actually see,
right
through it.
Yeah,
which is nice.
right through it. There we go.
Which means
now I can't see the anterior crus. So I'm going to down fracture now because I don't see the anterior crus. I haven't got a good view of it. So let me have a 90-degree hook, laser on standby.
Yes, it's interesting. I do that as well, but Robert says that he feels with the drill. I find that.
Yeah, you've got to have a bit of a space to get through. And one like this,
and if that's fractured beautifully easily, hasn't it?
Yeah, it has. Yeah.
Across when it comes out, I bet it'll be quite thin.
I will. It's thin but quite long.
Yeah.
I don't know. Can you see it? Yeah, you see it. Yeah. Okay, so that's out. Put that to one side. Now, the next thing we're going to do.
Flatten off that bit of. You're going to drill that.
I will, and I will do that. That little posterior crus. Yeah.
It's just crumbling away.
There's not much to it. Actually, it's not really in my way. At this stage, what I now do, I like to get everything ready before I make a stapedotomy. So I need to check my drill, and we're using a gyrus drill, which I don't think they make anymore, which is a shame because what I like about this drill is it's got a very nice fine end, a bit like that autoprobe, so that you can see around, and also it's slightly longer than the other drills. Yeah, you can see there's really nothing to that posterior crus. So I'm not bothered about that. Okay, so the drill's working.
That's a big question. Yeah, I mean, I always use the Skeeter, which I thought was a fantastic drill,
yeah.
But the new disposable burrs don't seem to run quite as smoothly. And my current favourite is the B&Air, which is a nice drill.
Yeah,
lovely drill.
Well, I both the Skeeter and indeed the B&Air. The problem I have with those, and I have a B&Air now on your advice, and it is a really good drill, but I find when you're using a speculum, it's just a tiny bit too short, so that the body of it gets slightly in the way. I think if you do an Endor, it's probably a perfect length, and it's a European drill, and it's probably designed for the European Endoral market. But I think we should, club together and ask them to add on 4 millimeters for us.
Company. I'm sure they do that.
Sure they do that. Well, they might do. Now you can see there's a little bit of an ooze there now, so I'm just going to put a tiny bit of cotton wool with adrenaline on, just see if I can settle that down. Really small piece, Rosie. And then I'm going to go and prepare my vein graft. Actually, before we do that, can I measure, please? Can I have the measuring rod? So I measure to the undersurface of the incus and down onto the foot plate.
So that's interesting because you see, I measure to the undersurface, but Robert measures to the middle. So that's
well, that's really important when it comes to measuring and discussing lengths and all these things.
There's actually been a lot of questions about the measuring, and people have been inquiring as to what difference it makes if you're actually putting the graft in as well.
Yeah, so it obviously has to be long enough to get through the hole, Nina. This is slightly
Yes.
longer. I don't know if you saw, but it was to the top measure. So I'm going to put a 4.7, do 4.75. Most people, most of the time, put it in 4.5 millimeters. That's usually how it is.
Yeah, I think, Chris, Nina, the important point to make with this technique is that if you cut a piston that's too long, you will end up with the vein graft tented like a half-closed umbrella. You know,
Okay.
we try to cut it to the length so it's just touching the perilymph. And if you have a thick
Well,
foot plate,
yeah,
you would measure twice. You'd measure once like Chris
yeah,
is now,
that's true.
and then you'd measure again to the perilymph once you've drilled the foot plate. But this doesn't look so thick, so I think that measurement
No, I don't think
will
so.
suffice.
So we're going to go back
that's
to our
good
vein
to-
graft now. Okay, what you can see, it's sort of dried around the edge. And the vein graft, I don't know about the vein graft. I mean, I've used it all my career. It works well for me, but whether you need it or not, I'm honestly not sure. Let me a blade now and a needle. So what we do now is we raise the vein graft off the plate so that when it comes to having done the stapedotomy, we don't have to do this bit. It's already been done. It's just ready to go straight in. And you can see there's a little dimple on it, which we like. And I was doing a study with Wilco once, but unfortunately that never quite finished when we were trying to compare. Didn't get enough patients. Okay, and the next thing I'm going to do is take the piston, and I'm going to use the same piston that Robert Vincent used, which is a 5 millimeter. Sorry, it's a 6 millimeter long, 0.4 millimeter wide, large loop piston. It's made by Medtronic. It's Teflon. And that's the one, yeah, they're just showing me it. I'll show you in a second. And that we can cut to length. You can just see here, my stapes, you see the anterior crust there? That nice thin anterior crust, just by my finger. I'll zoom in for you.
Chris, I was just going to
With
say,
the laser burn at the back. And you can see really beautifully here what John was talking about. Can you see that? How it's almost a C-shaping cross section. So it's got thick and very thin in the middle. It sort of makes a little curve. There's a sort of gap. You see that? It's nice.
Mhm.
Yeah. Okay.
Chris,
Right,
just talking
let's
about
zoom
the
out.
vein,
Yes, go on.
you do see,
Yeah.
you do see patients that you talk to who've seen colleagues who say, and I've been told I can't lift my baby for 2 months afterwards or any weight more than 2 kilograms.
Yeah.
I must admit, I don't really have any restrictions with my patients after day 2.
Yeah.
I obviously don't want them going doing powerlifting, but I do believe, I honestly believe that the vein graft means that they can, do the things that we have to do in everyday life, like raising intra-abdominal pressure to lift a suitcase or even.
Yeah, I think you're probably right. I mean, I agree with that.
I mean, it must protect you. It must, but we can't prove it.
So I've put that into 4.75. You can see when you look from the edge that this has got a little countersink, and that's to account for the width of the loop on this piston. So if you don't have that countersink, you'll be putting a slightly longer piston in when you measure it, because you'll have the extra length of the width of the Teflon. Okay, I think that's going to be the right length. It might be a tiny bit long.
Zomed block, isn't it? Zomed block.
This is yeah, that's right. And then we just open up the loop like that, so that hopefully it will be easier to put in. Okay, so now we're going to go back to our foot plate. We've got the staples on that. We've got the vein graft ready, and we'll go back. And what we're going to do now is our stapedotomy. So we're going to adjust the settings on the laser now to 750, so 3/4 of a watt, and 200 microseconds. And then we're back down on our
we've got a
foot
very
plate.
interesting question that's coming about incus necrosis. We'll cover it at the end.
Okay, so the incus necrosis is interesting because I've got a revision to do later, which I think probably is an incus necrosis. And actually, it's a Teflon that I did myself 10 years ago. And I haven't had many revisions of my own ones, but, it'll be interesting to see. I've done both ears on this lady. I did one ear on her 12 years ago, and that's absolutely fine. And this one, 11. Okay, so we'll just focus on the foot plate.
That's it. That's
Okay.
it. Perfect. Perfect.
You happy? Decent view?
That's a really good.
Okay,
Yeah,
let me have the laser now, please. So we're just going to do a little laser rosette. on the foot
Are the
plate.
settings the same, Chris?
So now I've
So when you
reduced
did
it now. So I've gone down to, so I started off with 1 watt continuous, and now I'm on 3/4 of a watt, 0.2 of a second. Laser on, please.
Okay.
And we do a little rosette, and you take your time on this, because there is a little bit of heat that gets through into the inner ear.
And for those watching, what Chris is trying to do and what Robert was trying to do is we're trying to turn the bone of the foot plate into charcoal, because the drill really then acts as a fan, not as a drill, so there's no vibration. And that's
Sort of tries to
probably the benefit of
blow
laser.
away that little bit of charcoal.
You can see I think you can see the perilymph pulsing there, Chris.
You can, yeah. There you go, and that's the stapledotomy. So just drop straight through.
So literally hardly had to do anything there, did you?
Hardly anything, hardly anything. And now we're going to put the vein graft on.
So, John, we were discussing this before. We didn't get to talk about it, about from the time that you open, from the time that you perform your stapledotomy to the time that you obviously insert your prosthesis. I mean, we were talking about the whether it's a critical time, whether, you know, there's a length of time which is ideal, a length of time which is too much.
Nina,
Just
I
for
don't
the
think
people
the
that are
difference
listening.
between 1 minute and 5 minutes matters, but I think if you leave it open for 3/4 of an hour, I mean, when I'm operating,
Right.
my anaesthetist gives one shot of either augmentin or ticaplane, and I know other people don't do that, but normally it's only open for maybe a minute or 2 minutes, because you've prepared your vein graft, you've prepared your
Yes.
prosthesis, and the only time it's open for a long time is if you haven't got some kind of seal over it and you can't get the prosthesis in.
Mm.
But having said that, if you don't have a seal, it's still open once the prosthesis is in. I mean, Thomas's stapledotomy will still be open for another 24 hours until blood clot and loose connective tissue
John,
and fibrin fill the
Yes.
gap. Yeah.
John, I like to disagree, because if you saw
Yeah,
what
sure.
Thomas did.
Okay, guys. So I've put the vein graft on, and I do like to try and make sure that that hole is open for as little as possible. And it's not so much the hole being open, but every minute that that's open, you're more likely to get a bit of blood coming down and going onto it, and that's, you know, that's a pain. And then you have to clean it, and so you really want to do it as, you know, have it as little as you possibly can, I think. Sorry, Wilke, what were you were saying?
No, I like to point out that
disagreeing with me.
Thomas sealed the open labyrinth with venous blood that he drew.
Oh, right.
So,
I didn't know that.
No,
Okay,
you didn't
apologies.
pay attention. I know. And so in that sense,
I didn't see it.
he
I didn't
didn't
see it.
leave it open.
Yeah.
And to the viewers that are aware, and I can see a lot of responses to that, it was Mr. Oates that was distracted. Okay.
That was upsetting the Germans. Leaves.
It's now to Chris.
Yeah, sorry. So I'm just trying to get this. And what I like to do, if possible, is line it up so I can get it into the hole and then just pop it on. What's happening is it's just catching back of the canal. There we go.
Chris,
Okay, 90-degree hook.
Do you give any antibiotics, or have you given up on that?
I don't give antibiotics.
Yeah.
Right, so there we go. So if you can get it in the hole, and then you just, from behind, just push it. Yeah, they get steroid. And I'll have a crimper now. There you go. So I think that's it.
Nice. We've seen two really nice crimpings. You and
pretty
Thomas
fine.
have done a very nice one.
And then we can just give that a little prod. Definitely in place. Okay. Right. Thank you. I think that's done.
Good.
And then, so basically, we put the drum back. I use just a little bit of Merigel, which is hyaluronic acid. It's made from the cockscomb of cockerels from male chickens, from the bit on the top of their head, bizarrely.
Chris,
And yes.
Is that
Yes.
called the McGee crimper?
Is it called what? Sorry, Core?
McGee.
I had
McGee.
the idea it was the McGee crimper.
Yeah,
People
you know,
have
I'm-
difficulty to trace that crimper because this is a very slim and good one.
It is a nice, I mean, I have to say, I think all the instruments when you do ear surgery, it makes such a difference if you've got slim shafts to the instruments, because it just means you can see better. And I think that with the drill, I think that with the, you know, with the crimper, all these instruments, I think it's really important.
Yeah, I particularly like
Just
when I'm
let me have a
using
spot,
needles
please.
in them, particularly
Yep.
transcanal. I like angled needles because it enables your hands to move laterally by a centimetre or so, which means
Yep.
your thumbs, which, you know, in males tend to be fairly large, don't occlude the field of view.
Yeah, Marigel, one more piece of Marigel, and then we are done. I'm just telling my niece to
Good.
declare that we are finished. And yeah, and so we will meet shortly with another case, which is a
Can I put in
tympanoplasty with a
another
cycloplasty.
question to you.
Yes, yes, please, Core.
In the
Yeah.
discussion between the Chambo and the Andol incision approach, in my view, you can judge preoperatively it is too curved to work easily without an Andol incision and, let's say, a bony widening plasty of the external ear canal. I think you will have had along also such cases where it is really narrow to work along. Could you confirm that too or not?
I sort of agree with you, except I just virtually never ever do that, Core. But I know what you mean. I mean, there are certainly cases where it's very tight. I've just found over the years, I've done so many per canal that you can really work through a tiny, tiny entrance. And of course, you can always do a bony meatoplasty per orally. But I don't know, you know, I'm certainly not saying one thing's better. It's what you're used to. And I know when I go to Europe, loads of my colleagues and online, of course, perform beautiful surgery through endorals.
Yeah,
But
I mean,
just
Chris,
don't really use them.
I
And
love
funny enough, I was brought up when I trained in Newcastle, and there was a guy, John Dawes, who I'm sure you would know, Core, John Dizzy Dawes, who used to go to Nijmegen on the course there.
Yes.
And they did everything endorally, and they used to do him and A, B, and C incisions. Even their mastoid surgery, the full blown mastoids, they'd still do that through an endoral and take it as a him and C. And that's what I was trained to do, but I have to say I don't do it much. Very, very rarely.
I have to say, Chris, I love the endoral, and I used it for all my mastoid surgery, but I wouldn't dream of doing an endoral for a stapes. And as I said, like you, I've had to do it once. I've had to do one endoral slit, not an endoral incision, an extended one, out of 1,300 cases. So anyway, there's an interesting question that's come up here. Thanks for this great broadcast. In the experience of the panelists, what are the causing factors associated with long process incus? Well, the unanswerable question, I suppose. But
I wish I
what
knew
do
the
the
answer to
panelists?
that.
What wish I knew? Yeah, yeah. I don't think any of us know, but I'm not. Well, I'm not sure. Well, if certainly there's a theory that if you crimp too tight, it's going to cause a problem, and if you hit the incus with the laser, as we've seen in years past, that's going to cause a problem. But what do you think? Wilco, you're a great laboratory animal. What causes incus necrosis?
Well, John, I think in theory we need to discriminate between incus necrosis and incus erosion, I believe.
Yes.
And I think necrosis means a vascularization issue. And if you look at the publications, there are definitely also publications that claim that if your perforation in the oval niche is not wide enough, that will cause mechanical wear and tear, which will give you erosion. So maybe it's theoretical, but I think we need to discriminate both. I've always been quite baffled. How can we take out an incus in mastoid surgery, leave it in the mastoid, and it doesn't erode, doesn't do anything, or necrosis? And with stapes surgery, we see necrosis. So I think there's definitely a vascularization issue potentially, because the arches of the stapes will bring up some blood as well, as we know. But I think mechanical wear and tear, I think that more or less aligns more with the time interval that we see with incus necrosis. I mean, incus necrosis, like Chris will have a revision, I think, later on. After many years, you see it. And I think it's more likely that that's mechanical wear and tear than vascularization, if you ask my opinion. But there's no science to that. Maybe Chris, I can see Chris is close to the microphone. Maybe he still wants to say something.
Yeah, I mean, I honestly don't know. I mean, I've always felt that the incus, the stapes prosthesis shouldn't be too tight around the incus.
No.
Although I quite like this Nitibond prosthesis. It's got sort of 3 points of contact because I feel it doesn't strangle. But yeah, I mean, this lady I'm going to do, I don't know if she's got incus necrosis, but I suspect she has, and it's 10 years, and that would fit with more wear and tear rather than an avascular issue. You'd expect that would come on reasonably soon.
Exactly.
I don't know, and you see it with every prosthesis. I mean, you see it with wire, you see it with Teflon. I mean, I think people even talk about seeing it with bucket handles.
Okay, there's another question.
Yeah, I mean, I've moved over towards the bucket handle more and more, but I've had one with a bucket handle, so I don't know what it is.
Okay, John, there was one more question from me actually to see the response online, but I see that Munich, and we have not had Munich in the broadcast yet. So I propose to go to Munich to see what they're.
So being sent for our next patient, yeah.
And John, so we go to Munich. Hello, Munich. Joachim, can you hear us?
Moment. Yeah, hello.
Hello, guten Tag. Yeah.
Wilco, good morning.
Good morning. Good seeing you or good hearing you.
Yeah, I hope you see my picture. That's better than seeing me.
Well, if you're not the patient laying there, then we see your hands and we see the patient, yes.
Good. So this is a left ear, and this is the patient who had undergone ear surgery, most probably a stapes surgery, and in January 2020, she experienced a respiratory tract infection and a sudden hearing loss. Now she has a conductive component, and meanwhile we found out that there was a stapes prosthesis inserted 4.25 millimeter. So we are aiming for stapes revision surgery. And we are doing the end oral approach with the Hermann incision. Sorry for being a compressor, a bit quick with the first stapes, but this went nicely. So we'll see what we will find here. Okay, kleines Messer. Loslassen.
Joachim, can you confirm that we're looking at the audiogram right now? Can you see the screen of the broadcast? Is this the audiogram of the patient?
No, this is a different patient.
Okay.
This is the patient of the first side with the primary surgery.
Okay.
Sauger. But she has a normal inner ear and a conductive component. Rinne tuning fork test is negative, and that's why we are going to explore this. Können wir bei uns mal das?
Joachim, we've seen 3 operations with a transcanal approach, and you're now doing an end oral. Would you like to tell us why you believe this is beneficial?
Oh, well, that is very simple. I was trained in the way to do it and orally, Sauger. And the reason for that is, well, we did it, and I learned it from Helms this way and continued. And the reason or the rationale behind is to get a little bit more space when opening up, and that's why I continued. Bipolar.
So the main reason is what we'd all say with our various techniques. It's what we're happy with.
Yes, but the reason is, you will see in a minute, Freya, you get a nice and wide, scharf, a nice and wide opening, and this is the main reason. We create a triangular flap to enlarge the entrance, the entrance Sperre. I honestly must say I have no comparison if the space is really more spacey compared to a transcanal approach, because I have never done the transcanal approach. But I have no reasons to doubt. Jetzt ein bisschen spülen und.
Well, I don't think, Joachim, it really matters. As we say, there's a lot of ways to skin a cat. It's what you're happy with.
Well, yeah. Well, that's right. And we discussed this 2 years ago in the course of Bessier, that in stapes surgery, you hardly change your technique. You stay very long with what you learned and what's proven to be good before introducing any changes or changes of the prosthesis or whatever.
Good morning, Professor Muller. It's Nina
Picture
here.
is okay?
Yes, it's good. Professor Muller, can I just ask, we didn't
Yes.
see you do any preparation of the ear. Did you put some local anesthetic or adrenaline in before we saw you?
Did you put in plaster?
Any local anesthetic or any adrenaline?
It is the complete injection of a ear block with local anesthetics, even if it's under general anesthesia. We used to do this under local, but now people feel for comfort, let them choose general anesthesia. Bellucci. So we do the classical local anesthetics as usual with ultracaine and adrenaline 1 to 200,000. And you see some scar tissues. So this is classically injected and make it a little bit
Great,
nice.
thank you.
And for the younger listeners, we always do in all ear cases the local anesthetics before washing and wrapping the patient, so that the drugs have time to act. And at the time when you cut in, you have the reduced bleeding through the adrenaline. And we always use a complete injection in the front of the ear through the ear canal and from the backside. Bellucci. Abgewinkeltes. Now you see at the suction tip there is a hair. This is something the surgeon has to control to avoid foreign body granuloma or inner ear depression, which is said to come from particles brought through the instruments into the middle ear. So. Haben wir einen Bohrer? There's a little bit of new bone formation on the Bellucci, on the top of the ear canal, which I will drill away.
So, Professor, you mentioned that this is a revision case. When did she have her original surgery done? When did she have her original surgery? How long ago was that?
Where?
How long ago was the primary surgery?
2015.
Okay.
2015, and a sudden hearing loss, which turned out to be a conductive after upper respiratory tract infection in January 2020. And due to COVID, she avoided surgery, and now she want to have it done. And so we could bisschen mehr Kabel.
So did you do any preoperative scanning to find out what the reason might be?
Yeah, we did a
As to the
CT
change.
scan, and it should be also in the PPT, which I sent to Robert. I think this would be case number 2 or number 3. I'm not quite sure, but you find a CT scan with a prosthesis in the middle ear, which does not reach the vestibule. And
Okay.
well, we found out yesterday when renewing the anamnesis that it was a stapes surgery done. From the picture, we had the impression that it's also a dislocated middle ear prosthesis, but this could be cleared yesterday.
Okay. Thank you.
Schwarzer Sauger und den abgewinkelten Teller. So now we are go open up the egg and see what we will find. Sicher? In the depths, I can see the chorda. This is posterior mallear ligament, some scar tissues. Some scarring.
Yeah, that's great. You can see
There
that.
is a prosthesis. And my assumption is that the prosthesis is too short and does not reach the vestibule, but we will control. Lester? Eine 4,5 mal 0,6 mm K-Piston-Prothese bitte aufmachen.
That's a great view now.
Sichel? Hauslöffel, großer Haus, große Seite. You see, this is picture, Foto bitte. Und Video starten bei uns. Okay. Prosthesis is somehow down to the vestibule. Get a little bit more space and access.
Yes.
Sauber machen. Kann der nächste in die Holding. Sichel? Kleiner Seite, kleiner Haus, großer Haus, kleine Seite. Sorry, we have somehow to switch to German with my scrub nerve. With me is Katharina helping, having sorted out all the instruments that might be needed.
That looks like a very good curette that you're using
She's
there.
giving you a beautiful curette. She obviously loves you.
Yes.
That's what I asked for. Yesterday we had some stapes surgeries. No, not yesterday, last week. And the curette were awful. Großer Haus, große Seite. So we have
So
to
you asked for
change
one
them.
yesterday. The way it works in the UK is you ask for one in 2020, and they will put it on the budget for 2026.
Yeah. Thank God you have left EU, huh? And so we did
Yes,
not come to that.
yes. It's very lucky.
Kleines Schwämmchen.
There's very few adhesions here considering previous surgery, so that's nice. And a really good view of the facial nerve.
Ja. Den Haus noch mal ein bisschen weiter. I will try to get a little bit more space and access to see really what's happening to the end of the prosthesis in relation to the foot plate, because I simply thought it might have slipped out. Kleiner Haus, große Seite. Now you see, we also have bad curettes like this one.
Well, your bad ones look like our good ones. But do you use a facial nerve monitor? Do you use a facial nerve monitor for
we use
revision?
it.
Yeah. What about primary?
Yes. Well, the simple thing is we use it for all ear cases, independent if we like it or need it or not. But if you, I hate the question every morning, do you need the facial nerve monitor? So I decided I use it in all cases, so I have it ready every morning.
Okay, that's a very good information, a good bridge. Thank you, Joachim, because we're now going to go to a surgeon that's absolutely not using the facial monitor, I think. Robert, can you hear us?
Yeah, but Robert has nice nurses.
Yes, we can hear you.
Yes, that's right, Joachim. They are very nice, very nice. And that's very important in terms of results and way of doing things.
Okay.
I'm not sure. Are you listening to me? Can you hear me or?
Yes, we can see you. Yeah.
Yes, we can hear you.
Okay.
You're sitting some cartilage, taking some perichondrium, I think.
Yes, I tried because I could see that the tympanic membrane is not really good, but the problem is that I have trouble to elevate the perichondrium flap because the quality is not good. I think that some part of the cartilage has been taken during the previous operation. You notice that this is a revision case with a fade prosthesis.
Mm-hmm.
So I try to, sometimes it's usually easy to find the cleavage plane, but not in this case. Really bad.
Robert, very good. I'd like to go to Joachim because he's now with the prosthesis.
Okay, no problem. Yeah,
otherwise,
go to him.
Otherwise, I put picture in picture, okay? Joachim,
go to him. Go to him. I'll be
we're going to go back to you, Joachim.
Yeah.
Because I see the metal prosthesis.
This is a Richards platin wire Teflon.
Uh-huh.
And in revision, I like to remove the scar tissue down to the oval niche as a first step to have no adhesion before pulling out the prosthesis. Ein 45er, noch eine Nummer größer. Moment.
Okay.
Der K-Piston ist auf.
Robert, we're briefly back with you as well. Robert?
Yes? Can you see me?
Yes. Well, we
all
can
right.
see the ear.
Okay.
Yeah.
So I took a graft, but I'm not really happy with the graft itself. So I see if I need more, then I have to go to the, but now it's bleeding a lot. I have to go to the, I have to take maybe the perichondrium from the concha, but I would make a decision later on. At the moment, I have problems with the bleeding. So I have to coagulate.
I think best if we let you coagulate that and we watch the piston being removed by Joachim.
Yeah, I think it's better.
Okay, Joachim, we're back with you. We're watching you trying to mobilize the piston.
Yeah. Ja, dann das 2 Ringe 50er. Well, what we can show later on is to make it easier for Katharina to handle me. The instruments, they have marker rings. So I ordered a ring with a 45-degree hook with 2 rings, which means it's the second shortest. But this is really a nice help for the surgeon as well as for the scrub nurse. And we will show this at the end of the surgery if you're interested. Eine Nummer kleiner. Look, there's the perforation, and the prosthesis is not going into the vestibule, and I slipped it just off. Photo. 90er 2 Ringe. Yeah, it's 4.25, what we have learned from the record yesterday night. And so we will put in a 4.5.
You can actually see the perilymph pulsating and it's not touching.
Yeah.
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 Very good.
Yeah. Professor Muller, did she actually have a good result initially, or has it never been good? Because you said it was back in 2015.
She had a good result initially. '90er, eine Nummer größer. And a sudden event caused the hearing loss. And in audiogram kriegt der Dr. Wiebringhaus für die Histo genau das, was jetzt aufkommt.
So you're going to put a 4.5 in?
Yes. Nochmal ein Häkchen, eine Nummer größer. Und vorher hätte ich gerne noch das Schüppchen.
So I missed it as well. Did you perform the previous surgery? Was it elsewhere?
No, it was not me, but it was
that looks
done.
Like a crura. I say because that's a crura.
It was done in our clinic. Echt? Und dann das kleine Schüppchen. Maybe next year I can show you a surgery where I was the previous surgeon.
Oh, I'm sure that never happened. Not in Germany.
45er. Und einen Stabessauger bereithalten. Look, this one, you see the carbon, this was done with a laser before, you see that?
Yes. Yeah.
I'm a friend of manual perforations. Hecht und die Prothese. Stabesgabel bereithalten. Jetzt müssten wir mal einen Moment Ruhe haben. Gib ihr nochmal, wie schwer ist sie? Gib ihr nochmal 250 SDH. Dann haben sie was zu tun. The anesthesiologist, who is very nice and charming, is Dr. Lewandowski, and her beloved color is black.
Can we ask her what the blood pressure is? Can we ask her what the blood pressure is?
150 to 64.
Okay, thank you.
Nadel. Do you mean Dr. Lewandowski's blood pressure or?
No.
Mine?
We'd been talking in the previous case about hypotension.
Well, I think a good local anesthetics with adrenaline is better than hypotension. Now you see the chorda is direct in view of the prosthesis.
Yes.
Made for lion. Schließzängelchen.
Well, I'm afraid the maker, whoever you believe in, when he was designing the ear, put it in the worst place he possibly could. And in fact, interesting, the chorda, because the chorda always comes up in discussion. If you stretch it a lot or damage it, do you cut it or do you leave it and hope it will recover?
A good question. If I stretch it a little, I would leave it. And if I stretch it a lot, I would cut it.
Good. We were asking the session at the end of the day what the other surgeons will do.
Moment. You see, this forceps has a groove to fit with the with the band, and the crimping is a two-step procedure, in my opinion. First, close it, and then tighten it. But this is not tight enough. Okay.
We are going to have a quick look in France.
Well, just Wilco, let's just watch the last 5 seconds of the crimping then.
Jetzt mal das 90er Häkchen.
Okay, fantastic.
Kleines.
Thank you very much, Joachim. Very good.
Yeah, we will not the free end. We will close kleiner and loop it, and then we're done.
Robert, we are with you.
Okay, good to hear. Nice demonstration by Joachim, as usual. So, so I'm doing now the tympanomental flap elevation. I'm going to show you the tympanic membrane in a minute.
It's a little dark. Can you lighten up a bit?
Yeah, I will increase the light. Sure. Hold on.
Dr. Vonson, can you tell us, that's better, thank you. Can you tell us a little bit about this case, please?
Yeah, this patient has been operated before by another surgeon, and we have an immediate failure. And so I don't know exactly what has been done. I didn't have any file. What we have now is you can see a really atrophic tympanic membrane here with a piece of cartilage here. I think this is the Malleus handle, and this is probably the stapes head, but there's no view of any reconstruction. So we'll have to perform an ossical reconstruction. I intend to perform a TORP reconstruction, a TORP with the Grace medical one and the sylastic bending technique. So you see there is a huge gap between the Malleus and the stapes head. So I will use the Malleus relocation technique, of course, to reduce this gap, and also the sylastic bending technique if the stapes is intact. So we will define, we will see that soon. So I've already performed this tympanometal flap elevation, and now we are entering the middle ear cleft in a second. We can see here, this is the quarter tympani. So I try to preserve it, but it's not easy. And I think I will do the same as Joachim. And if it's overstretched, then I think it's better to cut it. Where some surgeons, and maybe they are right, they say it's just like any regular nerve. You must have to
Robert,
not to cut it. So
can you please confirm that? Is this the audiogram?
Yes, that's the case number 2.
Yeah, I think it is.
That's it. Yeah, that's it. But the difficult part that I have now is to dissect the tympanic membrane, because I don't have a very nice graft, so I don't want to have a complete perforation at the end. You see the retraction here?
Yes.
So I need to dissect the retraction with the fine needle. Still trying to preserve the chorda tympani, the chorda tympani right here. Here we go. And you have this retraction here. You see that? Very atrophic.
Yes.
Yeah. So I need to elevate this retraction. This is something here which might be some graft or cartilage. I don't know. Yeah, that's a cartilage. And I don't like that. It's really big. Ok, un plus petit, s'il vous plaît. Are you sure about the quality? I think it's really highlight, right?
No, it's
Is
good.
it better like
No,
this?
it's fine. It's fine. It's fine. We've got a really
Okay.
good view of the corda there. Somebody managed to expose the corda beautifully last time.
Well,
We've just had a
not sure.
comment from one of the viewers, Dr. Vonsant, saying lovely work.
Thank you.
Safa Ayas.
Yes.
Probably a Frenchman.
Oh, it's a friend. I'm sure it's a friend.
Yeah, he knows you're
This is
directly
a-
descended from Napoleon.
That's the
Machiavelli.
problem with this. That's the, you know what, that is the problem with this piece of cartilage reconstruction. I know when Joachim does cartilage tympanic marble grafting, it's very nice because it's cut and fine, and like Wilco, they all do well. But I hate when the previous surgeon did this kind of thing, which is just put some piece of cartilage without
So
making it thin.
it's full
so then
thickness,
it's
isn't
really
it? It looks full. It looks full thickness.
Yeah, really
Because I
bad.
think even with your careful dissection, you're going to end up with a big hole, aren't you? That's the problem. It's
Yeah,
not your
it
fault.
could be like this. Yeah, could be, but it's not a, well, if it's like this, I have to take a graft from the concha.
A bigger
So we'll
graft,
see.
yeah.
Anyway,
Oh,
let's
Robert,
try.
this is live surgery. That's why it's so helpful for the people watching. It's not what we
But,
can
you
do on a
know-
video. It's what we can do when the chips are down.
And this is also some skin here, so I need to dissect this skin. It's important not to leave it here over the stapes head. And of
Hey,
course, the
John.
problem is that I don't want to dislocate the stapes.
Yeah, that's clear. Hey, John, that's why you're moderating.
Yes. You're so cruel, Wilco. So cruel.
He's a nice friend of you.
Just
Well, you know,
remember, next
John,
time
you-
I take him out
you
in the
know-
boat, I won't check his life jacket.
Yeah, but you know, John Wilco does the same now every day in the clinic with me.
Yeah, I
eh?
know.
So,
I know.
So it's only once, sometime with you, but it's every day with me.
Yeah, John, imagine how difficult it is with me.
So difficult.
I think Wilco, it's just a nervous response when you're in the presence of experts. It's yeah, one can understand.
That took a while to think.
You've done a great
Okay,
job,
now I
Dr.
can
Vonson, of
remove this,
dissecting out that cartilage. Yeah.
Thanks. I don't like it. I hate that. Really, how can you think it's going to work if you put cartilage like this? I can criticize because I didn't put any name, so I won't talk about the previous surgeon, but I just talk about what is my opinion in what has been done. And again, this is really bad, you know. Again, this piece of cartilage. How can I do my graft now? Because it's just inside the middle ear cleft, so I need to dissect it and try to remove it. So that's a good thing to show to young surgeons and to other surgeons, because if you want to do cartilage tympanoplasty, you need to make it really thin, not like this.
Yes. Yeah.
Nina,
Never
can you address the question?
Yeah, so Dr. Vonson, we just had another question come through from one of the viewers, just talking about the fact that obviously you're elevating this graft and you're removing the cartilage graft, but what happens if you do inadvertently cause some dislocation of the ossicles whilst you're doing that?
Well, that's the problem. We always have to try to avoid that. But if this happens, if you dislocate the stapes, my opinion is that in this case, it's better to stage the surgery and not to put any prosthesis, because I mean, you just leave the stapes, reposition the stapes, and put some interposition, or I mean, not in position, but I mean graft or fat tissue or something like that.
Yes.
And then you leave it like this, and then you wait at least 1 year, and then you can come back and try to put a prosthesis. Because if you put a prosthesis on the same stage, then it's really bad. You see how it is? It's really bad.
Yeah.
Really
It's not
bad.
good, is it?
Viens démanger marteau. But I think it's a really good case for live surgery to explain the problem with the cartilage and try to avoid doing this.
Absolutely.
Well, there's a lot of controversy around the world about whether you should stage live surgery, but my personal feeling is that it's only when you see a surgeon operating live that you
Yeah,
see
sure.
how to deal with these problems. Yeah, any of us can edit our video to make us look fantastic, but only these guys can do it live. And you know, it's really important that you're still doing it, and you know, we're all very grateful.
Okay, I'm checking now the tympanic membrane, and of course not the perforation, but I already took the piece of perichondrium, which I think will be enough because I have 2 pieces, so it should be fine. Let's see now. I can elevate the superior
Robert,
part of the flap.
I want to go
Yes.
quickly to Joachim because he's closing and he's using silicone, so I think it would be
I
nice
thought
to
you.
have
I
have
thought
a-
you wanted to go quickly to the toilets, but
I
it's all
already
right, you
did.
can go.
Yeah, thanks. Joachim, we're
Yes.
back with you. I saw that you put the Miato flap back.
Correct.
Yes.
Okay.
And we are putting gel foam inside, and this is sucked in an antibiotic. Noch nicht, erst die dritte Folie. For this, important to see to place the slides, the slices where the cuts for the tympanomeatal flap were, to avoid granulation tissue. And in stapes surgery, the package will remain for 7 to 10 days. After tympanoplasty, and the next case will be a cartilage tympanoplasty, we leave the package 3 weeks. Gelbe Schwämmchen. There's one thing
gel
more
foam
to-
with
to-
tried cortical or something on it, cream on it.
No, it's tetracycline.
Tetracycline, yeah.
Yeah. And well, we had in earlier days ointment stripes, but the ointment was not longer legalized to be used in the ear. And in stapes surgery, this is much more comfortable if you can take out stripes instead of sucking out these sponges, because the sponges are very loud and we should be aware of noise trauma when removing the package. But this was more comfortable in the early days with the ointment. But
Yeah, we still have the ointment. We've had a company that's made a replacement to Terracortical Otic, which is certified for use in the UK, and it's really
okay,
nice.
erstmal die Naht.
Okay. Thank you, Joachim.
My
We go back
pleasure.
to- We go back
Very
to
good.
France. Bye-bye.
Yeah, thank you.
So, Robert, you're bearing the malleus. You're using a sharp needle to get through the
Yeah.
periosteum.
Yes,
Maybe
that's
if you
what I
talk us
do.
through
You
that.
see, what I'm doing, I'm doing an incision through the periosteum of the malleus, so, and then elevating a periosteal flap. Now I'm at the level of the umbo, and I have a problem with the umbo because again there's a piece of cartilage which I remove already now, so it's fine. And I'm
Well,
trying
getting
to
the hook
dissect
around the
now
umbo is very difficult, isn't it? It's difficult.
Yeah, always. Specifically in this case where everything is atrophic. So you need to, when you have this kind of thing, we really need to follow the bone all around. Like this, I think it should be okay now. I need to remove that ciso. But of course, I'm increasing the size of the perforation, but I don't have any other choice. Okay, right. Now I think it's fine. This is only adherence, so it should be okay. Let me see if everything is elevated. Yes, it is. All right, so here it's fine. So I need to elevate more superiorly like this. Because of course, if I want to relocate the malleus, I need to entirely separate the malleus from the tympanic membrane and not only partially. Now, elevating the superior part, this is the short process.
Some people would think it would be nice to remove the incudial remnant at this stage, but if you do that, the malleus just flops around all over the place.
Exactly.
So it's best
Yeah,
to
that's a
leave it.
good
It's not touching the stapes, so it's not a problem.
Yeah, that's it. You're right. And I will remove it after that. Okay, there we go. I think it's fine. Okay, I have some adherence here. I will remove them because it depends on the placement of my graft. Okay, all is fine now. So I can now remove the incus. And I will use a hook for that. Okay. I don't want to increase the body rim resection because I have some risk of retraction, so I need to deal with this. There we go. Rotating movement, and you notice that I'm using a rotating movement, and that it's fine.
Yeah.
And again, it's important to say that this is a transcanal approach again, same thing. All right, so now I will cut the tensor tympani tendon with this, going
It's a good
close
view there.
to the bone. Sorry?
That's a really good view, actually. It's the tendon, and
All right, good.
we can see it clearly.
All right. Is it better like this?
Yeah, that's great. Thank you.
Okay, so I'm now overstretching the anterior ligament, grabbing the malleus with the hook like this, and then pulling the malleus back like this until I reach the posterior wall. So I know that if I can reach the posterior wall, it means that I've already overstretched the anterior tympanomallear ligament. So you see now you place the malleus over the stapes head. And that would be a nice way now to place a prosthesis in a vertical way.
And when you did it, Robert, I noticed you put the hook fairly high up the incus. The malleus to prevent fracture.
Exactly, because if you do that too low, you can fracture, dislocate the malleus. Yes, that's right. So now I remove this band here because I want to have a clear exposure of the foot plate, which I think we have now. And I want to measure now the distance from the malleus to the foot plate. But first, I want to be sure that the malleus will be in a good position. So I need to reposition the flap temporarily before measuring. Otherwise, I will make a wrong measurement. But I think it's fine because, you know, the malleus has a tendency to go medialized, to be medialized here. So I will put my flap like this. I think this is the good position. I need to elevate a little bit more. Okay. The problem, it's always like this. The problem now is to determine the right length. Because if it's too short, and everybody understands it's not going to work. But if it's too long, there's a risk of extrusion, and it's not good. So it's important to have the right distance, which I think will be now. So you see, I'm sticking back the malleus to the tympanic membrane, and I'm going to measure. This is an elongated stapes measuring rod, which has 4 notches instead of 3, running from 5 to 8. So I'm touching the foot plate right here, and you see it's very low, very small distance, only 5, which means that it's going to be, you see the low one is in front of the malleus, which means 5. So I will cut it at 5.5. I will cut the torp at 5.5. And to be honest, this is the limit for me. If it's below 5, then I use a torp, CISO, because I know that I cannot place the torp in good position. Now I'm cutting the stapes tendon because I will put the band underneath the stapes tendon. And now the next step will be to put the graft. I will work on the graft to have a nice graft. And only at the end, I will put the torp. Everything is ready now for the torp. So now we need to put the graft. Let me see what we can do with that.
Dr. Vonson, can I just ask a question about the malleus
sure.
relocation? You did it very, very gently and very carefully. You were talking about overstretching the anterior malleolar ligament. What happened if perhaps, you know, it was overstretched or it became very unstable? Would you change your approach?
Lose. Or you mean lose malleus, right?
Yes.
Well, could be a problem. I have the solution now with the malleus replacement prosthesis, of course.
Okay.
But it's always better not to use it. I mean, to prevent that. But you know what? Even when you have a really loose malleus, in the vast majority of cases, when you put the torp, it's decreasing the mobility of the malleus. So it's you know, it's making something.
It gives it some
stabilize
stability.
the malleus also.
Okay.
Okay, I will put my graft here. I will try to preserve this part, which is not really good, but I don't want to remove that. Otherwise, I will have a total bufferation, which I don't want to have. So let's see if I can work like this. If not, then I will go for conchal perichondrium. All right. So I have 2 parts of graft. Let's see with the bigger one first. Okay, I show you the graft first before taking it. So this is the first part of the graft, which I think should be okay.
That's good.
Looks good, yes.
You prefer this to
Okay.
fascia?
Yes. Well, if I take a fascia, then I need to go for posterior incision, so it's not the same. But fascia is good, of course. You remember that Benoit was doing always fascia. So now we need to place the graft. And I tell you, it's not going to be very easy. Oh, la spi marche pas très bien là. I have to take it again because I have to change my sucker, which is not doing well. Okay, let's see what I can do with this. Okay, just elevating the flap again and trying to place it over the Mallet handle, of course, on the right. And under the tympanic membrane. It's going to be a little bit of a time to be sure that I will stretch the graft correctly, which is not the case yet, as you can see. Okay, it's trying to stick it like this. You know, I try to place the graft between the, in the left, between the residual cartilage and the tympanic membrane. Now let's see if I can stretch the superior part of a graft. If I'm not happy, I will remove it completely and try to reposition it differently. I need to stretch it over the Mallet handle like this. This is good. This area is good. I don't have any doubt that here is going to work, but I'm not sure about the inferior part of a graft. So I need to check. Now I reposition the flap and see how it goes. Looks good, but I need to check it completely. Okay, let's try it now. Reposition the flap, sticking the residual tympanic membrane to the graft. Of course, this is the good part of the graft. Now the worst part is there. We know that. Usually I put the graft over the bony canal wall, but I can't really do it here. Maybe I have to elevate a little bit more here. Okay, let me see. I have to elevate more the flap. And then I think I will be able to do it. Décolleur, s'il vous plaît. Okay, calmez, s'il vous plaît. So you see the annulus here?
Yes, we can see it.
Okay. Ciseaux, s'il vous plaît. Okay, calmez. Okay, let's see what we have now. I need to stick it more anteriorly, because at the moment it's not good enough, of course, as you can see. I have some adherence there. Sometimes in this type of situation, the only way is to remove the entire tympanic membrane and do a total flap, total graft, but I really don't want that. You see, we still have an uncovered part of the perforation here. I need to push the graft more anterior.
So Dr. Vonson, we just had another question through YouTube from Jose, who's asking about grafts being dry or wet in terms of preserving viability. Do you have any preference? I mean, it looked like your graft was quite dry before you put it in.
Yes, because it helps me to put it in. So I prefer to keep it dry, and then you can see it's becoming wet very easily now. But at the beginning, I prefer to. Well, it's really difficult to have a nice graft in this case.
That's
I don't see any difference.
That's looking better there.
It's just more easy to place it when it's dry.
Yeah, I think I agree. I always dry out my grafts if I can.
You do that.
It just
too.
makes them easier to handle. Yeah.
Yeah. Okay, that sounds better now. I will cut this ciseau. Okay, I think it's not bad. All right, now I need to check the inferior part of a graft. Calmez, s'il vous plaît. Putting the prosthesis would be fine. The most difficult part is the graft in this case. So you see, I need to reposition the annulus on the right way, which was here, going here, and here. Okay, now it's fine. Okay?
Yes.
Okay, now it looks good. We have a complete closure of the tympanic membrane. All right. So now what I'm going to do is to place the prosthesis now. I'm going to elevate the flap. Vous pouvez me donner une petite lame élastique que je la laisserai. And I will put first a small elastic sheet in between both sides of the tympanomeatal flap, because I want to avoid the postural graft, not graft, but skin sticking to the anterior part. And it's because then it's becoming really difficult to find a cleavage plane. So I put a small elastic sheet in between, and then I will elevate again the posterior part of the flap and put the prosthesis. This will help me to find my cleavage plane between the anterior part of a flap and the posterior part, and also I leave it post-op to protect the graft.
Okay. We just had another question, just saying that it looks like a very, very good field. It's pretty bloodless. Can we just ask what the blood pressure is, please?
Now, quelle est la pression artérielle? On est à combien là? 60 systolic.
Wow.
Okay. Yeah.
That's pretty low.
The French are very strong. You know that. Now, my anesthetist, Martin, is very good. Stop. And I'm working with Celine, that everybody knows since the beginning of Lion and all who went to the course.
Remember Celine.
And the second one is Florine. She's also very good. I'm very lucky to have such a nice team with me. It makes a huge difference, as we all know.
Yes.
Okay.
I mean, working with the same anaesthetist is a marriage made in heaven, isn't it? It makes your life so much more pleasant. Yeah, it really is teamwork.
I'm not sure that the comparison with marriage is the best one, but
well, my anaesthetist was with me for 30 years, and he knew what I was going to do before I did it, and vice versa, which is the same as, you know, it's really important. So if you could talk us through the prosthesis is really important. Really good.
This is the Grace Medical Torp, which I designed with them. I wanted to have a torp coming with the silastic bend in the middle. You see that? Because at the beginning, when I was introducing this technique of silastic bending, you remember, John, we had to, and you did it also, we had to trim ourselves the bend from a silastic sheet, and it was not so good. So now it's coming with the prosthesis. You can see the bend coming with the shaft, through the shaft, which means that now the bend is very nice and easy to place, more easy. So the head of a prosthesis is made in adducts lapetite with a central groove in the center of the head, which means it's designed for malleus relocation, of course. and then the titanium shaft, which I can push through the head and cut it and put it back. So it means I want to cut it, remember, at 5.5. I measured 5, but I have to take into account the deepness of the groove, which is 0.5. So then I need to cut it at 5.5. And to cut it at 5.5, I have to push it first to 4.5, like this, okay? And then I will pull it back at 5.5. So here we go. This is again the limit for torp. Less than 5, it's not really good to do it. So I move to a torp. Okay, so I'm going to cut now the proximal part of the shaft like this. And then you can see if I pull it back, now we're going to go to 5.5. All right? You can see it, right?
Yes, we can see.
Okay. Now, the only problem is this. This is why I don't go less than 5. You can see this Teflon connection between the head and the shaft. And this is a little bit long sometimes. And if the distance from the foot plate to the stapes to the malleus is lower than 5, I know that this will be a problem. And I try to remove it. You can easily cut it, but then the torp becomes not really stable. So sometimes I prefer to move to torp, but let's try now with this case. So we have now the bend coming with the prosthesis like this, and we're going to put it now. I think I need to push a little bit up the bend like this. Okay, so let's place the prosthesis now. I can do so. So the first step for me is to introduce the prosthesis and to place the distal tip of the titanium shoe to the foot plate. And we'll take care of the malleus later. First, the foot plate. I'm introducing it with the sucker, as you can see. There we go. I know that the silastic is posterior, so I need to turn to rotate the torp. And then I will introduce the malleus within the groove. So you need to use both hands again. I definitely think that it's important to have both hands free. Otherwise, with one hand, it's becoming really tricky to do it. And my people can do that with one hand, but I will not be able to do it. All right, so so now you see the malleus is anterior to the groove. So I will hold the prosthesis with the sucker and then introduce the malleus within the groove. And it becomes more easy now. Not enough. I need to pull it a little bit more, and it will be fine. Okay, so it's really a step-by-step procedure like this, and it goes down nicely into the groove in a second. There we go. Okay.
Oh, that's great.
I really have to. I take my hat off to both you and Grace. I mean, it's wonderful when companies like Grace and Kurtz actually have engineers that will sit down with you and will produce what you want, and it just makes such a difference, doesn't it?
Yeah, that's what they do. And the same with Kurtz, with Uwe Steiner, who is now with Medel. But Uwe was really nice to design with me the malleus replacement prosthesis. Okay, so now I have to put the silastic band around the stapes. It could be nice like this, but I want to increase the chance of stability. So I will put it underneath the tendon. Of course, this is the tricky part. Now it's fine, okay?
You're saying that it's tricky, but you're making it look very easy, Dr. Bonson.
Well. I've done that so many times, so it's not like Freddie Mercury. Eh? It's not a kind of magic. It's just work. Okay. So let me try that. And you see now, if you move the prosthesis, you can see that the stapes is moving just like a single unit, and that's what I mean. There's no tilting; they are moving together, which I think is fine. But now the thing is that we need to check if everything is fine. The horrible time is when you put the tympanic membrane back, and you can see that the torp is too long. then you have to remove everything. So I hope it's not the case. Doesn't look like. Oh, the tension is
So
good. It's pretty good.
we're just having some comments on the Zoom chat about what the long-term results are with this technique,
well,
and how it compares to other techniques.
Yeah. The best is to go to otology neurotology, because we published a big series of that several years ago with all the results. But the long term is good. I mean, it's just like every other type of reconstruction. When the question is, you see, I'm just before answering the question, I'm just elevating again the flap to be sure that the prosthesis stays in place. A good trick is to tell you that if the prosthesis is too long, when you do this, when you reposition the flap, the prosthesis is moving backwards, which is not the case here. So it's good length. So I think it's fine. So I mean, the risk is to have an extrusion, and I've got a really low rate of extrusion. I don't remember by heart, but I mean, it's really low rate. And the success rate is really good and stable with time. The point is that I compared my result between the use of a TORP and between the use of a TORP plus elastic bending in case of Austin cartouche group A, which means presence of malus in stapes. And I definitely had much better results, statistically significant, when I was using TORP and elastic bending compared to PORP. That was, in fact, that was first described by Bill Moretz, our friend from US, was the first one to say, despite the presence of stapedial arch, he is better to use a TORP. That was his idea. And then I must say that it's true also in my hands. So it's really good. There we go.
Yeah.
So I'm going to now the mirror cell. Okay, allez-y. Okay.
I've just shared the reference now anyway, so everybody can have a look at that abstract and look at the results if they can get the paper if they need to.
Yes, I think it's good. Yeah. Because I don't have the real number now in my mind, so it's better to go and see it.
Okay.
But I will.
There's another question.
Publication.
There's another question. The general consensus, perhaps, is that autographs are best. Do you agree? Well, obviously, Robert would agree, and I would agree. I don't know about anybody else.
It depends what we are talking about. In terms of risk of extrusion and biocompatibility, of course, that the autograph is the best. But in terms of hearing results, in our hands here in the Cost Clinic group, we got better results with prosthesis rather than autographs. Okay. Also, the problem with the autograph, you sometimes don't have residual incus or residual malus, so it's not always easy to drill out residual bone. And it could be fixed completely to the stapes. I've been seeing that in many cases where I had to revise, and the transposition was completely bony fixed to the stapes head, and it was really a nightmare to remove it. So I really prefer to use prosthesis.
Thank you. We need to go back to a message of the sponsor as well, because we need to get those in as well. And that means after that we will go to Chris, as far as I can judge. Robert, thank you very much. See you later. Bye.
Bye-bye.
Thank you.
Welcome to the Luminis presentation. My name is Simon Smith. and the Europe, Middle East and Africa brand manager for the Head and Neck division. I'm going to be taking 10 minutes of your time this morning to take you through our company and our CO2 solutions, including the Otolays, which you've seen in action in this morning's case. So I'll start by talking to you about who Luminis are as a company and the system that was used in the case this morning. And following that, I'll walk you through the system components, the technologies we have, before finally moving on to the pathology-specific solution that we have in the Otolays. So who are Luminis as a company? Luminis are the world's largest medical laser company. We are a global developer, manufacturer and distributor of laser and light-based devices for surgical, aesthetic and ophthalmic applications. We have over 900 employees as a company and a global distribution network that operates across our various business, surgical and aesthetic units. We have 265 patents and have 260 plus FDA clearances with a global install base of 80,000 plus. In addition, we have a presence in over 80 countries across the world. So let's start by talking about the CO2 laser system that was used in today's surgery. The system itself has two main modes of operation, utilizing free beam and fiber-based technologies. The free beam, the energy is delivered through the articulated arm in conjunction with the operating microscope or the handpieces. When using the operating microscope, there's a choice of 3 AccuSpot micro manipulators, and that depends on the model of operating microscope that you're using in surgery. The SurgiTouch scanner is used in conjunction with the digital AccuBlade or the DAB, a semi-robotic linear cutting within the larynx or the airway. The CO2 fiber-based technology provides the precision of the CO2 laser energy, but overcomes the line of sight problem when using a surgical operating microscope, and I'll come on to a little bit more about that shortly. The fiber lasers can be used deeper within the airway and easily within the oral cavity. The Otter laser is used specifically for otology surgery. The AccuPulse Duo itself has application uses in otolaryngology, MaxFax, plastics, gynecology, and also thoracics. It's an upgradable platform. For example, it can be used in aesthetic applications. As you can see from the bottom of the screen, we have a wide range of CO2 laser accessories. So let's focus on the SurgiTouch scanner and the digital AccuBlade. The SurgiTouch produces shapes from the energy which is provided by the AccuPulse Duo. And it can be used with handpieces to produce circles for ablation. It can also be used with the AccuSpot with the digital AccuBlade with the DAB. Produces lines or curves for cutting. The scanning micro manipulator is able to produce unprecedented precision and reproducible results for the surgeon. So when the surgical objective is to treat the pathology with the maximum possible control, while minimizing adjacent healthy tissue damage, and also preserving organ functionality, the DAB micromanipulator is an indispensable tool to precisely incise, excise, or ablate the tissue. What does that mean for the patient? It actually reduces the risk of complications and increases the patient's quality of life. An example at the bottom of the screen there is the different modes. For example, circular ablation, linear and curved incisions, and also ablation. Let's focus a little on the depth of penetration. So the CO2 laser has the smallest zone of thermal spread in comparison with all other energy-based devices. So in theory, the depth of tissue penetration for the CO2 is only 0.1 millimeters. But for a surgeon, that means unprecedented precision and the ability to operate near really critical structures and delicate anatomy, such as those in otology cases. So let's summarize the digital AccuBlade, but it's virtually char-free laser delivery, which ensures clean excisional margins, has reproducible tissue effect. The system has preset parameters customized to the treated tissue and patient's anatomy. As mentioned before, the system is compatible with all the leading surgical microscopes. It also gives the surgeon maximum control as his incision shape, length, and depth and orientation are easily adjusted by the surgeon. The SurgiTouch scanning movement may reduce the procedure time when compared with conventional CO2 laser microsurgery. And finally, minimal heat buildup in tissue equates to accelerated healing time. So for the patient, fewer post-operative complications. So I mentioned before that I would elaborate further on the line of sight problems. So with the traditional CO2 laser microsurgery setup, the laser can really only be fired in a straight line, and usually that's around 400 millimeters. So if the targeted tissue is not in the line of sight of the operating microscope, it's going to be impossible to treat that with the CO2 laser. For example, in the lower airway tract or the pharynx. For that reason, Luminis launched the fiber-based technologies the CO2 a few years ago, for example, the fiber lays. This can be used either through the dedicated handpieces or through the working channel of an existing flexible scope with the endoscopic protection sheath, such as the bronchoscope or the transnasal esophageal scope. Fiber lays comes in two options, the single-use or the multi-use fiber, which is called the Endure. The Otolays is a fiber delivery system to perform ear surgery cases, such as a stapedectomy, cholesteatoma, and also adhesions. Finally, in the bottom right of the screen, we see the drop-in guide, which enables the fiber lays to be used with the Da Vinci robot. So let's move on to the Otolays. So we know that the goal for middle ear surgery is the restoration of sound conduction in the middle ear. What are some of the risks associated with middle ear surgery? Excessive sounds, vibrations, or heat during the surgery can cause temporary or permanent adverse conditions. For example, facial nerve damage, hearing loss, tinnitus, vertigo, or nausea. With the Otolays, we have three different system components. We have the fiber, which can be used up to 24 times. We have two reusable handpiece options and two single-use tip options. In addition, we have an improved fiber drape. So moving back to the handpieces, they're ergonomically designed, they're thin, they include a grasping mechanism, they're easy to maneuver and hold, and will facilitate clear sight visualization for the surgeon. There's a selection of two single-use tips, which are either straight or they're curved. Both of these options are highly durable and facilitate reliable energy transmission. The total working distance would be the combined length of the handpiece, the shaft, and the tip, which will allow adequate operation with the selected microscope. So on the left of the screen is an example of a complete starter kit, which includes a box of 12 curved tips, 12 straight tips, a straight handpiece, curved handpiece, which is a complete starter kit. So here's an example of the complete assembly of the Otolays kit. So firstly, we have the fiber, which is the piece that connects into the system, which is either the AccuPulse Duo or the UltraPulse Duo. Covering that fiber, we have the sterile drape. And the fiber is connected to the handpiece, either the straight or the curved handpiece. Finally, to complete the assembly, the tips are connected, the straight or the curved tips are connected to the handpiece. So what are some of the clinical benefits overall of the Otolays system? Well, the Otolays support tissue. And for the patient, there's less chance of vestibular injury. Overall, the non-contact